Aduh, jangan gitu dong, beli.
Saya juga satu lemari tuh, Mas. Nah, ini Bang Hariri, selamat siang, mohon dibantu untuk co-host. Kemudian ini lagi 10 menit menuju pukul 14, kita mulai saja add peserta. Mohon arahan lebih lanjut, sepertinya sudah clear semuanya, jadi pukul 14 sampai 14.15.
Mas Irfan sudah siap ya, Mas Irfan?
Mas Irfan?
Siap.
Mas Irfan belum gabung ini.
Sudah gabung.
Sampun.
Oh, sudah ya.
Oke, kemudian mohon izin menunjukkan di Zoom sebelah, Zoom Hong Kong. Zoom Hong Kong saat ini masih belum mulai. Bisa dilihat ya, oke. Ini nanti relaynya, kemudian cara relaynya adalah saya akan spotlight seperti ini. Demikian. Dan memang agak cembung sedikit, mohon dimaklumi. Nah, kira-kira sekian.
Rekam dari layar ya, beli.
Iya. Kemarin kita coba dari web. Nah, ini ada satu lagi kunci, Bang. Nanti sebentar saya coba. Cuman saya nggak berani gambling, yaitu antara aplikasi dengan dua aplikasi bisa. Saya akan coba nanti. Kemudian kayaknya sepertinya juga tidak bisa jalan bagus seperti kemarin kita juga coba via web. Kemudian ini bisa diinstal dua aplikasi. Saya akan coba nanti sebentar, mungkin sekitar 5 menit. Kalau itu gagal dan putus patah-patah, seperti web itu patah-patah, kemarin kita nggak berani meneruskan. Akhirnya ya kita balik lagi ke tembak layar begini. Kemudian suaranya pakai yang stereo dan dengan amplifier. Begitu, Bang. Jadi mohon dimaklumkan untuk yang pertama gini.
Yang udah di trial. Daripada ntar
ya, yang kemarin sudah di trial ini. Oke. Ya. Sepertinya seluruh peserta sudah bisa dimasukkan. Dan saya akan coba fokus ke Zoom sebelah. Absensi sudah siap saya. Nanti
Ini peserta kita masukkan semua ya, atau dikasih masih dikasih informasi dulu untuk rename dulu.
Masukkan semua, nanti setelah di dalam baru rename, Mas.
Siap.
Dimasukkan saja. Selamat siang para peserta CPD ASIA kelima. Absensi saya posting di chat, dan chat mohon maaf saya batasin untuk ke host saja, host only. Kemudian absensi ASIA CPD.
Ya udah.
Kemudian, ya, peserta sudah tidak diberikan akses untuk unmute sendiri. Selamat siang, Bapak-Bapak, Ibu-Ibu peserta. Mohon dapat mengisi absen yang sudah ada di kolom chat Zoom, Bapak-Bapak, Ibu-Ibu. Dan mohon disampaikan jika absensi ada yang Oh ya, masih belum accepting. Oke, sudah, silakan. Bisa di accepting sekarang. Mohon disampaikan jika ada yang kurang cocok, kurang tepat, atau tidak bisa bekerja di kolom absensi. Kemudian kita akan coba untuk live YouTube Pari Official. Dan saya ingin menyapa dulu MC kita pada siang hari ini, Mbak Irma. Hello Ir, how are you today? Are you ready for making a history? Master of Ceremony. Oh iya. I haven't set you up as a co-host. Now you co-host. Okay, please. Please, Mbak Irma from Bali.
Ya, selamat siang, Liputu. Apakah suara saya kedengaran?
Selamat siang, Mbak Irma. How are you today? You look beautiful
Great, how about
today.
you?
I'm good. And where are you now online from?
Saya dari Tuban, Bali, melaporkan dari Tuban, Bali.
Yes. Oke. Belum bisa absen. Oke, Bapak-bapak, Ibu-ibu silakan sudah di open, sudah di accepting response di kolom absence. Dicoba, jika tidak bisa absen, mohon disampaikan kepada kami akan perbaiki linknya. Kemungkinan ada link yang kurang tepat, yang kurang cocok gitu. Respond receive always, limit to one respond dihilangkan. See summary, oke. Collect emails, oke. Show progress bar, oke. So link, ya, so link to submit other response, oke. Confirmation message-nya, terima kasih telah mengirimkan absensi. Tidak ada door prize ya, mohon maaf. Bagi peserta dengan nilai oke. Ini saya hilangkan. Ambigu nanti. Tidak ada door prize, I'm so sorry. Kemudian make this quiz immediately after each submission, dan ada point value-nya. Oke. Rekan-rekan nanti setelah selesai isi absensi, nilainya bisa dilihat langsung di layar. Bapak Ibu co-host, terima kasih banyak atas waktunya. Jika ada hal yang ingin dikomunikasikan, bisa menggunakan chat WA grup untuk fast respon. Di saya chat WA-nya sudah diletakkan paling depan. Demikian. Dan operator video pada siang hari ini adalah Mas Ervan. Selamat siang Mas Ervan. Sudah siap?
Siap. Selamat siang.
Oke, terima kasih Mas Ervan. Ini juga ada yang komplain ini, baru mulai sudah komplain ini atas nama Putu Juli Artana Kewah. Pertanyaannya beli itu bahasa Bali. Yang artinya kok sulit-sulit banget pertanyaannya? Enggak kok, enggak sulit, enggak ada yang sulit. Asal mau dibaca ya. Kewah pertanyaan itu perasaanmu aja. Lanjut, silakan diisi absennya. Dan Bapak Ketum sudah hadir bersama kita dari sejak tadi pukul 14.45 untuk memantau jalannya CPD Asia kelima ini. Dan nanti beliau akan memberikan sambutan dan juga membuka acara. Kemudian setelah dari CPD Asia Link Indonesia ini, oh saya ada muncul dua di layar Mas Hidayat. Setelah beliau membuka acara di sini, kemudian beliau akan langsung menuju ke Zoom host di Hong Kong. Kemudian nanti cara kerjanya adalah kita bersama-sama menyaksikan. Oke, saya menghilang dulu sebentar. Kita sama-sama akan menyaksikan link Zoom dari Hong Kong, dari host utama. Saya akan munculkan bagaimana keadaan layar Hong Kong sekarang. Layar Hong Kong belum memulai acara. Mereka akan mulai pukul 15.00 ya, 15 waktu Indonesia bagian barat. Demikian kabarnya. Kemudian di CPD Asia kelima ini sedikit berbeda dengan CPD Asia sebelumnya, yaitu kita menggunakan 3 Zoom dari masing-masing negara. Oke. Saya online dari rumah ini. Begitu. Kemudian Indonesia dengan Zoom 500 peserta, kemudian Hong Kong dengan 1000, Vietnam juga. Dan masing-masing nanti akan merelay dari Zoom utama, Zoom host di Hong Kong. Jadi kita sebetulnya adalah nonton bareng dari Zoom di Hong Kong sana. Dengan perubahan seperti ini, diharapkan kita bisa memberikan muatan lokal lebih banyak. Seperti misalnya ada pembukaan, kemudian ada lagu Indonesia Raya, kemudian ada Mars Pari, pretest dan posttest dan seterusnya. Oke, link absensi akan kami share baik. Link absensi bisa dilihat dalam chat Zoom. Dan Mbak Irma, is Mr. Gatot already present here? I'm not seeing him at the Zoom. So, selamat sore Mas Gatot. Okay, maybe Mbak Irma bisa menyampaikan dengan acara.
Ya, baik Bu Putu, terima kasih. Bapak-bapak, Ibu semuanya, jadi seperti yang disampaikan oleh Bu Putu tadi, CPD Asia yang kelima ini sedikit agak berbeda dengan acara yang sebelum-sebelumnya, karena kita bergabung dengan sistem relay nanti. Pukul 14.45 kita akan bergabung dengan main Zoom dari Hong Kong. Untuk itu sebelumnya kita bisa melakukan muatan lokal sebelum acara utama dimulai. Jadi nanti akan ada, setelah pembukaan, kita akan bersama-sama menyanyikan lagu Indonesia Raya dan Mars Pari. Kemudian diikuti oleh sambutan Kepala Bidang Hubungan dan Kerjasama Internasional dari Bapak Gatot Santosa. Kemudian diikuti oleh sambutan oleh Bapak Ketua Umum PP Pari, Bapak Sugianto, kemudian kita akan melakukan mengheningkan cipta, diikuti dengan doa. Kemudian baru kita akan bergabung dengan main Zoom dari Hong Kong, dan kita akan mengikuti webinarnya. Jadi webinar pada kesempatan kali ini akan diisi dengan 2 topik, yaitu Radiation Protection in Paediatric Imaging, dan juga Computer Aided Detection pada USG Thyroid. Kemudian setelah pemaparan materi oleh presentasi dari radiografer dari Hong Kong, akan diikuti dengan tanya jawab dan penutup. Seperti itu kurang lebih. Jadi nanti kalau Bapak-Bapak, Ibu-Ibu ada pertanyaan terhadap presentasi yang disampaikan, nanti bisa langsung via chat atau pigeonhole ya, Bu Putu?
Ada pigeonhole-nya nanti kayaknya.
Betul, betul Pak Safi.
Oh ya, siap.
Info yang akan diberikan oleh Mas Ervan.
Iya, jadi nanti akan diberikan link pigeonhole sehingga Bapak-Bapak, Ibu-Ibu bisa menyampaikan pertanyaan, dan pertanyaannya akan kami forward kepada pemapar materi dari Hong Kong, yaitu sehingga bisa dibahas. Seperti itu kurang lebih. Ya, dan perlu kami sampaikan juga, jadi acara ini merupakan kerjasama dari organisasi profesi di Asia. Jadi yang awalnya acara ini digagas oleh PARI, Perhimpunan Radiografer dari Filipina, Macao, dan Vietnam. Kemudian baru saja bergabung sejak bulan lalu dengan kita, yaitu Perhimpunan Radiografer dari Hong Kong, Taiwan, dan Kamboja. Jadi totalnya ada 8 asosiasi radiografer yang join dengan acara ini, dan acara ini merupakan acara sharing ilmu antar radiografer di Asia seperti itu. Jadi semoga kita semua bisa mencapai apa yang kita harapkan bersama ya, yaitu mendunia radiografer Indonesia seperti itu.
Betul Irma, mantap, luar biasa. Ya, kita udah CPD yang kelima ini ya. Yang pertama dari Macao, kemudian 2 Indonesia, kemudian Filipina, kemudian kemarin dari mana itu yang keempat? Macao lagi ya? Ya, dari Macao lagi, kemudian yang kelima baru Hong Kong ini.
Ya.
Yang keenam kita akan umumkan, jadi hampir setiap bulan ada acara CPD Asia ini.
Ya, Bli Putu,
Silakan,
mungkin banyak yang bertanya, apakah kalau ikut acara ini mendapatkan sertifikat, Bli Putu?
Ya, sertifikat dapat, sertifikat CPD Asia, namun untuk menjadi SKP harus diajukan dulu ke pengurus pusat sesuai dengan SK 088. Ya.
Ya. Siap.
Kemudian untuk SK-nya bisa rekan-rekan, bapak-bapak, ibu dapatkan, lihat di pari.or.id. Baik, sudah berapa pesertanya, Ir, yang join di Zoom Indonesia ini?
131, Bli.
Oh iya, kita nanti targetnya sesuai dengan peserta yang kemarin sudah mendaftar itu 503 peserta, kemudian kita cek ternyata banyak ada data yang ganda, sehingga data ganda kita hilangkan, menyisakan 455 peserta yang sudah kita kirimin via email. Demikian informasinya, Ir.
Ya, siap, Bli. Ya, Bli, saya menambahkan seperti yang dikatakan Bli Putu tadi ya. Jadi acara ini rutin kita gelar setiap bulan. Jadi setiap bulan itu hostnya berbeda-beda. Nah, bulan ini hostnya adalah Hong Kong. Kemudian bulan Juni nanti kita akan mengikuti acara yang sama dengan host dari Vietnam. Kemudian bulan Juli hostnya dari Kamboja. Kemudian bulan Agustus nanti host kita adalah dari Macao. Seperti itu, Bli Putu.
Baik, terima kasih, ya. Kemudian setelah ini ada pembukaan, kurang lebih lagi 5 menit ya. 5 menit menuju pembukaan, saya akan online-kan di YouTube Pari Official ya.
Siap, Bli.
Live on YouTube. Oke, kita akan online di YouTube Pari Official. Pembicara kita pada siang hari ini siapa aja, Ir, yang dari Hong Kong itu? Ada 2 sepertinya.
Ya, kita ada 2 pembicara. Yang pertama adalah medical physicist, yaitu Mr. Adson dari Queen Elizabeth Hospital Hong Kong. Kemudian yang kedua ada Profesor Micahel Yong. Jadi beliau adalah associate head and professor di Hong Kong Polytechnic University. Ya, sepertinya 2 pembicara kita sangat luar biasa. Ini.
Dan itu merupakan pertanyaan dari pretest, Irma baru saja menyampaikan jawabannya. Silakan diisi langsung. Oke. Memang itulah tujuan utama dari webinar ini. Jadi sharing informasi, apakah informasinya bisa diterima dengan baik, kemudian kita berikan pertanyaan begitu, kalau memang benar-benar menguasai, mengetahui, pasti bisa menjawab pertanyaan tersebut. Ya, kita sudah live di link Pari Official. Ada 2 yang sudah menyaksikan pada siang hari ini, dan linknya akan saya sampaikan di kolom chat. Link live YouTube Pari official. Oke, Bapak Ibu yang mungkin mengalami kendala di Zoom bisa melihat di YouTube Pari Official. Sudah live? Ya, baru saja mulai di Zoom sebelah. Mungkin saya akan tampilkan bagaimana perkembangan di Zoom utama. Baru saja dibuka link. Ya, baru saja dimulai di Zoom utama. Wah, kacanya mantul dia. Tapi semoga nanti akan bisa samar nanti. Baik. Oke, 5 menit lagi, 1 menit lagi kita akan pembukaan. Dari Mas Ervan, apakah lagu Indonesia Raya, lagu Mars Pari sudah siap? Kemudian kami juga masih menunggu sambungan dari Mas Gatot. Apakah Mas Gatot sudah hadir bersama kita? Selamat siang, Mas Gatot. Ah ya, sudah. Selamat siang, Mas Gatot.
Selamat siang, Beli Putu. Selamat siang, teman-teman semuanya. Selamat siang, host pada siang hari ini, Ibu Putu Irma. Selamat bergabung dengan acara kelima dari CPD Asia. Kami dari bidang pengembangan dan hubungan luar negeri terus senantiasa bekerja sama untuk sharing kolaborasi dengan mitra kita sejawat di ASEAN maupun sampai ke Asia Pasifik. Mudah-mudahan teman-teman bisa menikmati dan bisa mengambil ilmu dari apa yang akan di-sharing oleh sahabat-sahabat kita dari Hong Kong. Terima kasih, Pak Putu.
Baik, terima kasih Mas Gatot. Kemudian kita sudah menginjak waktu untuk opening. Apakah kita bisa opening, Mas Gatot, langsung? Mas Ervan sudah siap dari operator, kemudian Mas Gatot sudah siap, Bapak Ketum juga sudah hadir bersama kita, dan peserta juga 150 sudah hadir, menunggu nanti sembari seluruh peserta masuk seluruhnya. Sepertinya kita bisa mulai opening dahulu. Bagaimana, Mas Gatot?
Silakan, Pak Putu. Terima kasih, Pak.
Baik, terima kasih, Mas Gatot. Live YouTube juga sudah berjalan. Kemudian silakan Irma untuk pembukaan dahulu. Tempat dan waktu dipersilakan.
Terima kasih Pak Putu. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Salam, nama budaya, Om Swastiastu. Yang terhormat Bapak Ketua Umum Pengurus Pusat Pari, Bapak Dr. Haji Sugianto, SPD MAPPSC, beserta seluruh jajaran pengurus Pusat Pari. Yang kami hormati, jajaran Kapengda seluruh Indonesia atau yang mewakili. Tidak lupa seluruh panitia beserta Bapak Ibu peserta webinar yang berbahagia. Puji syukur kami panjatkan kehadiran Tuhan Yang Maha Esa, karena atas rahmat-Nya lah kita bisa berkumpul di acara siang hari ini dalam keadaan sehat walaupun secara online ya seperti itu. Nama saya Irma, izinkan saya memandu acara ini dan tidak lupa saya ucapkan selamat datang di acara CPD Asia yang kelima. Jadi CPD Asia online ini merupakan kerjasama dari 8 organisasi profesi dari Indonesia, Myanmar, Filipina, Macao, Vietnam, Hong Kong, Taiwan, dan yang terakhir bergabung dengan kita yaitu Kamboja. Acara ini merupakan acara sharing ilmu antar radiografer di Asia. Dan pada kesempatan ini, pada bulan ini yang mendapat giliran untuk menjadi host acara ini adalah dari Hong Kong Radiographers Association. Dan acara inti akan dimulai pukul 15 nanti, dan pada pukul 14.45, seperti yang dikatakan tadi oleh Biputu, kita akan bergabung dengan main Zoom dengan sistem relay. Berikut izinkan saya menyampaikan susunan acara pada siang hari ini, yaitu pertama ada pembukaan, diikuti dengan menyanyikan lagu Indonesia Raya dan Mars Pari, kemudian ada sambutan dari Ketua Bidang Hubungan dan Kerjasama Luar Negeri, yaitu Bapak Gatot Santosa, diikuti oleh sambutan dari Bapak Ketua Umum Pari, kemudian mengheningkan cipta, doa, dan kemudian pukul 14.45 kita akan relay dengan main Zoom, kemudian dilanjutkan dengan acara webinar, dan kemudian tanya-jawab. Untuk tanya-jawab, nanti Bapak-Ibu bisa menuliskan pertanyaannya melalui link pigeonhole yang akan dibagikan oleh panitia. Baiklah, untuk selanjutnya yaitu menyanyikan lagu Indonesia Raya dan Mars Pari. Bapak-Ibu sekalian dimohon bersiap. Ya, terima kasih Mas Ervan. Untuk acara selanjutnya yaitu sambutan dari Ketua Bidang Hubungan dan Kerjasama Luar Negeri. Itu waktu dan tempat kami persilakan kepada Bapak Gatot Santosa. Silakan, Pak Gatot. Sepertinya masih di mute, Bliputu ya.
Ya, diulang lagi Mas Gatot, mohon maaf.
Oke. Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera Bapak Ibu semuanya. Kami dari bidang pengembangan dan hubungan luar negeri, saya sendiri dengan Gatot Santosa, dibantu dengan Ibu Putu Irma, kemudian ada Pak Lutfi, ada Pak Ali Amroji, dan tim yang lain. Pada siang hari ini berbahagia karena kembali kami kita bisa melaksanakan acara kelima dari online CPD. Seperti Bapak Ibu yang ketahui dalam slide bahwa tujuan dari acara ini adalah kita memperkuat hubungan relationship dengan organisasi radiografer di ASEAN maupun di Asia Pasifik. Kemudian kita juga ingin mempromot dan meningkatkan profesionalitas kita sebagai radiografer, bisa belajar dari apa yang kita nanti akan dengarkan bersama presentasi dari pemateri, dan tentu Bapak Ibu mempunyai resource atau mempunyai sumber referensi yang dapat digunakan di dalam organisasi lain yang sejawat kita di negara lain. Jadi mereka akan sharing knowledge. Tentu kita harus fokus untuk mengikuti acara ini, dan acara ini berlangsung dari mulai November tahun 2020 sampai dengan bulan Oktober 2021. Ya, terus bergantian dari satu negara ke negara yang lain. Bapak Ibu, semoga kita dapat mendengarkan. Selamat menikmati acara ini, semoga bermanfaat, dan selamat mengikuti online continuing professional development dari ASEAN Radiological Technology Society. Terima kasih. Saya kembalikan kepada Bu Irma.
Baik, terima kasih Mas Gatot. Berikutnya adalah sambutan dari Bapak Ketua Umum Pengurus Pusat PARI, Bapak Dr. Haji Sugianto, SPD, MAPPSC, MRI. Kepada Pak Ketum, kami persilahkan.
Baik, terima kasih Pak Putu. Selamat sore. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Om Swastiastu, Namo Buddhaya, dan salam kebajikan yang kami hormati teman-teman pengurus PARI Pusat yang menyelenggarakan kegiatan ini, khususnya barangkali teman-teman di bidang hubungan luar negeri, Pak Gatot dan seluruh tim, ya, teman-teman pengurus pusat di Pak Sekum, ya, kemudian teman-teman di HSIIT, teman-teman di Clin, dan Bapak Ibu sekalian, serta sejawat radiografer seluruh Indonesia yang bergabung ya pada kegiatan webinar di CPD ASIA pada sore hari ini. Puji syukur kita panjatkan pada Allah SWT, Tuhan Yang Maha Kuasa, atas limpahan rahmatnya kita bisa bertemu ya pada kesempatan yang berbahagia. Saya atas nama keluarga besar PARI yang menyampaikan selamat Hari Raya Lebaran untuk kawan-kawan Muslim. Mohon maaf lahir dan batin, minal aizin wal faizin. Mudah-mudahan kita selalu dalam lindungan dan keberkahan dari Allah SWT. Kami sampaikan terima kasih Bapak Ibu atas join ya pada kegiatan CPD ini. Jadi memang kegiatan CPD ini kita coba fasilitasi pada teman-teman radiografer di Indonesia. Jadi ini juga merupakan satu kesempatan ya kita bisa belajar dari kawan-kawan kita di negara lain tanpa kita harus datang ke sana. Jadi kita bisa belajar dari beberapa negara yang lain. CPD Asia ini awalnya memang diselenggarakan oleh 5 negara ya. Jadi dari Indonesia, Macao, Filipina, gitu ya, Vietnam, Myanmar, kayak gitu. Kemudian menambah beberapa negara ya, Malaysia, terus kemudian di Taiwan, Hong Kong, dan mungkin nanti juga akan terus berkembang. Jadi ini kesempatan yang bagus kita bisa ikut ya mendengarkan sama-sama pengalaman yang sekarang ini diselenggarakan di Hong Kong. Dan nanti kita bisa mendengarkan sama-sama untuk pengalaman kawan-kawan kita radiografer dari Hong Kong. Dan kami barangkali yang ini memang kegiatan yang kelima ya barangkali ya sudah beberapa kali ya. Memang formatnya berbeda-beda terus berkembang ya dari pertemuan yang dulu CPD ASIA pertama, kedua sampai ke yang sekarang ini. Dan di sekarang formatnya mungkin dengan relay ya Pak Putu tadi ya. Dengan relay terus kemudian masing-masing kelompok ini diberikan grup Zoom ya. Jadi ada beberapa negara diberikan 1 Zoom, ada beberapa diberikan Zoom gitu. Ini kalau nggak salah ada tiga kelompok Zoom. Nah, kita ini di Indonesia ini diberikan satu kelompok Zoom kalau nggak salah. Karena memang peminatnya cukup banyak, jadi diberikan 1 kelompok Zoom. Nah, ini juga akan memudahkan untuk kita semua ya. Nanti kita bisa relay, terus ada pertanyaan segala macam, silahkan untuk bisa dielaborasi oleh teman-teman, nanti bisa ditanyakan ya. Boleh dengan bahasa Indonesia ya, masalah ya. Nanti akan di-translate agak gitu. Dan nggak usah khawatir. Mudah-mudahan dengan adanya kegiatan-kegiatan seperti ini bisa menambah wawasan kita, membuka wawasan kita, bagaimana sih sebenarnya kegiatan-kegiatan radiografer juga di negara-negara yang lain. Ini saya kira ini yang kita agar tidak terkungkung ya di lingkungan di negara kita di Indonesia, tapi kita bisa melihat teman-teman kawan-kawan dari negara-negara yang lain. Nah, kemudian kami di kesempatan ini juga mengingatkan teman-teman radiografer untuk tetap ya selalu menjaga protokol isolasi dan kondisi COVID ini belum reda. Kelihatannya sepele, tapi ternyata itu sangat efektif ya. Kalau kita menggunakan masker, cuci tangan, juga cara ini untuk mencegah penularan dari COVID-19. Ya. Jadi ternyata belum berhenti, belum turun juga. Jadi kami minta betul ya, kita ikut serta untuk memutus mata rantai COVID-19 ini. Mungkin itu dari saya juga dalam perjalanan relay ini semua berjalan dengan baik ya, dengan lancar, sinyal bisa terkoneksi dengan baik ya, sehingga kegiatan yang nanti mulai jam 3 sampai jam 5 ini nanti bisa berjalan dengan lancar. Dan ini kayaknya baru dimulai yang jam 5, sebelumnya kan jam 3 ya, sebelum-sebelumnya jam 7 malam ya, tiap malam Senin itu jam 7 malam. Dan ini ada perubahan mulai jam 3 ya, nanti mungkin ke depan juga akan mulai jam 3 sore. Mudah-mudahan bisa mengganggu ya aktivitas kita. Saya kira demikian. Terima kasih semua panitia ya, teman-teman pengurus juga seluruh anggota yang bergabung ya dalam kegiatan ini. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Baik, terima kasih Bapak Ketua Umum. Berikutnya mengheningkan cipta akan dipimpin oleh Bapak Ketua Umum, Bapak Dr. Sugianto. Kami persilahkan.
untuk mengenang jasa para pahlawan yang telah gugur mendahului kita, teman-teman radiografer ya juga yang bertugas menangani COVID pasien yang gugur mendahului kita, mengeningkan cipta mulai. Selesai.
Terima kasih Bapak Ketua Umum. Selanjutnya, pembacaan doa yang akan dipimpin oleh Bapak Syafi'i. Kepada Bapak Syafi'i kami persilahkan.
Terima kasih Mbak Irma. Ya, Assalamualaikum warahmatullahi wabarakatuh. Mohon izin pada doa kali ini akan dibacakan dengan tata cara agama Islam. Bagi saudara-saudara yang memiliki keyakinan lain, mohon dapat mengaminkan doa atau berdoa menurut keyakinannya masing-masing. Sebelum berdoa, kami mohon juga berkenan ikhlasnya untuk kesehatan saudara kita, terutama Mbak Nuning, dan mungkin teman-teman kita yang lain yang saat ini sedang sakit. Mudah-mudahan Allah berkenan memberikan kesehatan dan mudah-mudahan bisa segera beraktivitas kembali bergabung bersama-sama kita. Biridhoillahi wa syafaati Rasulillahi al-Fatihah. A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Iyyaka nasta'in ihdinas siratal mustaqim siratal ladzina an'amta 'alaihim ghairil maghdubi 'alaihim waladdallin. Amin. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Hamdan yu'afi ni'amahu yukafi mazidah. Ya Rabbana lakal hamdu kama yanbaghi li jalal wajhikal 'azimi sultanik. Allahumma shalli ala sayyidina Muhammad salatan tunjina biha min jamil ahwali wal afat wa taqdilana biha min jamil hajat wa tutahhiruna biha min jami' sayyi'at wa tarfa'una indaka ala darajat wa tubalikuna biha aqsal ghayat min jamil khairati fil hayat wa ba'dal mamat. Ya Allah, segala puji bagimu ya Allah, yang awal tanpa yang awal sebelumnya dan yang akhir tanpa yang akhir sesudahnya. Maha suci asmanya, maha tanpa anugerahnya. Ya Allah, yang tak tersembunyi darimu apapun yang ada di langit dan di bumi. Bagaimana mungkin tersembunyi bagimu apa yang engkau ciptakan? Bagaimana mungkin engkau tidak menghitung apa yang engkau buat? Bagaimana mungkin hilang darimu apa yang engkau atur? Ya Allah, sampaikanlah salawat dan salam kami kepada junjungan kami, Nabi Muhammad SAW dan keluarganya. Salawat yang awalnya tidak terbatas, yang batasnya tidak berujung, dan akhirnya tidak berhingga. Ya Allah, ya Tuhan kami, Kami agungkan segala asma kebesaran-Mu, karena Engkaulah Zat yang Maha Mulia. Kami tadahkan tangan kehadirat-Mu, karena Engkaulah Zat yang Maha mengabulkan segala permohonan hamba. Dengan mengucap puji syukur kehadirat-Mu, atas segala rahmat dan karunia yang telah Engkau berikan kepada kami, pada saat ini kami hadir bersama di dalam acara webinar CPD Asia yang kelima ini. Untuk itu ya Allah, ya Rahman, ya Rahim, jadikanlah acara yang kami laksanakan ini sebagai acara yang Engkau ridhoi, yang membawa barokah, rahmat, taufik, dan hidayah-Mu. Ya Allah yang Maha Pengampun, ampunkanlah dosa orang tua kami, dosa guru-guru kami, dosa para pahlawan pendahulu kami. Sayangi dan muliakanlah mereka dari sisi-Mu. Ya Allah, ampunkanlah dosa-dosa kami. Jangan Engkau palingkan hati kami setelah Engkau beri petunjuk. Berilah kemampuan kepada kami untuk dapat mengamalkan ilmu yang Engkau karuniakan. Tiada daya dan kekuatan kecuali pertolongan-Mu ya Allah. Ya Allah, saat ini kami sedang menghadapi wabah pandemi corona. Banyak di antara saudara-saudara kami yang telah mendahului kami. Ampunkanlah dosa-dosa mereka ya Allah. Terimalah segala amalnya. Tempatkanlah mereka di tempat terbaik-Mu ya Allah. Ya Allah, ya Syafi, tidak sedikit pula saudara-saudara kami yang terbaring sakit karena wabah pandemi ini. Kami mohon sembuhkanlah mereka. Berikanlah kesembuhan yang tidak meninggalkan penyakit setelahnya. Ya Allah, karuniakanlah kepada kami kesehatan agar kami dapat menolong sesama. Ya Allah, ya Rahman, ya Rahim. Saat ini kami berkumpul untuk bermunajat kepada-Mu, karena hanya kepada-Mu lah kami gantungkan segala hajat hidup kami, segala keinginan kami. Lapangkanlah segala urusan kami, ya Allah. Tidaklah kami meninggalkan tempat ini kecuali telah Engkau ampuni dosa-dosa kami. Tidaklah kami meninggalkan tempat ini kecuali telah Engkau penuhi hajat hidup kami. Jadikanlah pertemuan dan perpisahan ini hanya karena-Mu. Berkailah pertemuan dan perpisahan ini atas rahmat-Mu. Rabbi adkhilni mudkhala sidqi wa akhrijni mukhraja sidqi wa ja'alni min ladunka sultanan nasira. Allahumma aslih lana dinana alladhi huwa ismatu amrina wa aslih lana dunyana fiha ma'asuna wa aslih lana akhiratana allati fiha ma'aduna waj'al hayatina ziyadana fi kulli khairin waj'alil mautana rahatan min kulli syarr. Allahumma ya Allah, perbaikilah urusan agama kami. Yang urusan agama-Mu ini merupakan benteng pelindung bagi segala urusan kami. Perbaikilah urusan dunia kami untuk kami, yang ia menjadi tempat hidup kami. Dan perbaikilah akhirat kami, yang ia menjadi tempat kembali kami kepada-Mu. Jadikanlah kehidupan ini sebagai tambahan bagiku dalam setiap kebaikan, serta jadikanlah kematian sebagai kebebasan bagiku dari segala dosa dan kejahatan. Rabbil firli wali walidayya warhamhuma kama rabbayani shaghira. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar wa adkhilnal jannata ma'al abrar ya aziz ya ghaffar ya rabbal alamin. Wassallallahu ala sayyidina Muhammadin wa ala alihi washabihi wasallim walhamdulillahirabbil alamin. Amin amin ya rabbal alamin. Demikian Mbak Irma, waktu saya kembalikan. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih kepada Bapak Syafi'i. Baiklah Bapak Ibu sekalian, demikianlah rangkaian pembukaan untuk acara webinar CPD Asia yang kelima. Untuk berikutnya, sebentar lagi kita akan bergabung dengan main Zoom dari Hong Kong untuk mengikuti acara utama. Diputu? Apakah kita sudah bisa terhubung?
Ya, sudah. Mereka baru saja mulai.
There is a very strong business community, and the whole Bay Area initiative is definitely very important to position even more Hong Kong as a center for business. Hong Kong is a very central place where everybody comes so easily to Hong Kong. It's an excellent place of people meeting together. Hong Kong is the world's meeting place.
The world meeting place.
Ya, mereka baru saja mulai.
Hong Kong is a dynamic, wonderful, safe environment. There's no reason not to come here as either a tourist or as a business traveler or as an attendee at an event.
对于内地客户来说，它不像海外，香港是非常重要的一个出口，在亚洲是一个比较重要的一个金融地位，是非常适合在香港举办这样的大型展会。
So Hong Kong has so much to offer. You have the heartbeat of an international financial city, but you also have beautiful mountains and beaches, a stone's throw away.
And there is a very strong business community, and the whole Bay Area initiative is definitely very important to position even more Hong Kong as a center for business.
Hong Kong is a very central place where everybody comes so easily to Hong Kong, and it's an excellent place of people meeting together.
Hong Kong is the world's meeting place.
The world meeting place.
Hong Kong is a dynamic, wonderful, safe environment. There's no reason not to come here as either a tourist or as a business traveler or as an attendee at an event.
对于内地客户来说，它不像海外，香港是非常重要的一个出口，在亚洲是一个比较重要的一个金融地位，是非常适合在香港举办这样的大型展会。
So Hong Kong has so much to offer. You have the heartbeat of an international financial city, but you also have beautiful mountains and beaches, a stone's throw away.
And there is a very strong business community, and the whole Bay Area initiative is definitely very important to position even more Hong Kong as a center for business.
Hong Kong is a very central place where everybody comes so easily to Hong Kong, and it's an excellent place of people meeting together.
Hong Kong is the world's meeting place.
The world meeting place.
Place of people meeting together.
Hong Kong is the world's meeting place.
The world meeting place.
Hong Kong is a dynamic, wonderful, safe environment. There's no reason not to come here as either a tourist or as a business traveler or as an attendee at an event.
对于内地客户来说，它不像海外，香港是非常重要的一个出口，在亚洲是一个比较重要的一个金融地位，是非常适合在香港举办这样的大型展会。
So Hong Kong has so much to offer. You have the heartbeat of an international financial city, but you also have beautiful mountains and beaches a stone's throw away.
There is a very strong business community, and the whole Bay Area initiative is definitely very important to position even more Hong Kong as a center for business. Hong Kong is a very central place where everybody comes so easily to Hong Kong, and it's an excellent place of people meeting together.
Hong Kong
is the world's meeting place.
The world meeting place.
Hong Kong
is the world's meeting place.
The world meeting place.
Hong Kong is a dynamic, wonderful, safe environment. There's no reason not to come here as either a tourist or as a business traveler or as an attendee at an event.
对于内地客户来说，它不像海外，香港是非常重要的一个出口，在亚洲是一个比较重要的一个金融地位，是非常适合在香港举办这样的大型展会。
So Hong Kong has so much to offer. You have the heartbeat of an international financial city, but you also have beautiful mountains and beaches a stone's throw away.
There is a very strong business community, and the whole Bay Area initiative is definitely very important to position even more Hong Kong as a center for business.
Hong Kong is a very central place where everybody comes so easily to Hong Kong, and it's an excellent place of people meeting together.
Hong Kong is the world's meeting place.
The world meeting place.
Hello, good afternoon, everyone.
Good afternoon, everyone.
We start at 3 o'clock, right?
Yes.
That's not the same last.
Yes.
We start at, hello, Luna, you will start first. And
yes, copy already. Yeah, already. Yes.
Hello, Nathan.
Hello. Nathan, good. Okay.
Oh, Sukianto, long time no see you. Just only by video.
Hello, Fernando.
Yes, more than 1 year.
Yeah. I will see you again.
I see Kim team also, okay?
Kimon Kim.
Someone massage. No.
Oh, Sawa.
Sawa.
Last time I see you in Myanmar, I remember.
Vietnam. Yeah, I see in Vietnam. We met in Vietnam.
Vietnam also, right?
Yes. Yeah, 2 years ago.
Yes. So time is going fast. Also, more 2 minutes we will start, right? Kim is not to join us.
That not join us.
Mr. Kim is so still some problem in Myanmar.
Cambodia not see, but
Cambodia also, yes. Sophie.
Nelson, you check in messenger group. I send message for you.
Oh, okay.
Thank you.
So Taiwan, Mr. Chun, how are you?
I'm fine, thank you. Can you hear me?
Yeah.
Okay, nice to meet you.
Okay.
Also today we have Indonesia, Taiwan, Vietnam, Malaysia, Hong Kong.
Yeah.
So for the next month is the Vietnam and Southeast Asia.
Yes.
As more on that time we will have more participants. All the times of
Okay.
Start.
We see equal. I see equal.
Oh yes, everyone.
We try connecting. Equal.
So we will start?
Yes.
Luna, please.
President Gili open video.
All right, starting.
Yeah. You bigger.
All right, starting. Okay, starting in 5.
You bigger.
1. Okay, starting in 5, 4, 3, 2, 1. Good day, everyone. This is CPD Asia. We are on the 5th online continuing professional development platform for Asian Radiologic Technologist societies. And hosting this event is the Hong Kong Radiographers Association. The member societies are grateful to VT Healthcare Vietnam and Bayer Vietnam in helping us to organize the Asia CPD. Now, to formally start the program, please welcome the Hong Kong Radiographers Association President, Sir Wan Shiu Boon Nelson, for the opening remarks.
Okay, thank you, Pichi, and welcome everyone. So first of all, dear the President Sugiarto from Indonesia, dear the President Philando Kok from Macau, dear Kumantin, the President from Myanmar, dear the Rolando from Philippines, dear the the President Tai Wan Loc from Vietnam, dear the President Sophia Lee from Cambodia, and dear the President To Chen Yun from Taiwan, and dear the President Sawa Masai from Malaysia, welcome. And ladies and gentlemen, on behalf of Hong Kong Radiographers Association, I would like to express our heartfelt gratitude to welcome all of the members from different associations. And this afternoon, we have two different speakers to go through the radiation protection as well as the ultrasound technique. I hope you all enjoy the coming lecture. Thank you.
Peachy, you have to turn on the mic.
Thank you very much again, President Wan Shu Boon Nelson, for that very warm welcome. So I continue now, ladies and gentlemen, supporting also this event are the presidents of the different RT societies and associations. We have from Macao Radiological Technologist Association, MRTA, Sir Fernando Koch.
Hello, good afternoon, everyone. I am Fernando Koch from Macau.
Hello.
From Indonesian Society of Radiographers known as PARI, Sir Giek Sugianto.
Hello, good afternoon, everybody. I am Sugianto.
This is also
from Indonesia.
Thank you. And this is also supported by Myanmar Society of Medical Radiation Technology President Kin Mountain, Cambodian Radiologic Technologist President Sophie Lee, and President Chun Yuan Tu of Taiwan Association of Medical Radiation Technologists, TAMRT.
Hey, hello everyone, I'm Jun Tu from Taiwan. Thank you.
And from Vietnam Association of Radiologic Technologists, President Thai Van Loc.
Good morning, my colleagues, everybody. Good morning, good afternoon, everybody. I'm Loc from Vietnam.
And we also have the President of Malaysian Society of Radiographers and RTs, President Sawal Marsaid.
Hi everyone, good afternoon. I'm Sawal Marsaid from Malaysian Society of Radiographers. Good to see you all. Okay, thank you.
And representing President Rolando Benares is myself, Peachy Luna, as also your MC this day. So thank you very much, dear presidents. They will again join us as panelists in the Q&A session. So again, thank you. Now, this CPD Asia, hosted by the Hong Kong Radiographers Association, has prepared two expert speakers who will share to us very interesting topics. And I would like now to introduce to you Mr. Bobby Hsu, the session moderator, to handle this part.
Hello, good afternoon, everyone. This is Bobby Hsu. It's my pleasure to be the moderator of today's online CPD platform. I am the academic secretary of the Hong Kong Radiographers Association, HKRA. Knowing that today's audience is our RT friends from all around Asia, including Vietnam, Philippines, Myanmar, Cambodia, Indonesia, Malaysia, Taiwan, Macau, Hong Kong, and maybe even other places, HKRA has made our best effort to prepare two interesting and informative presentations from two renowned speakers. The topics are radiation protection for pediatric imaging and ultrasound computer-aided diagnosis of thyroid cancer. We will put the Q&A session at the end after the two presentations. The speaker of our first presentation, radiation protection for pediatric imaging, is Mr. Adson Leung. Mr. Leung is a certified medical physicist of the Hong Kong Association of Medical Physics. Serving the Hong Kong Children's Hospital, Mr. Leung is specialized on dosimetry on pediatric patients. Apart from dosimetry in radiation therapy, he's also interested on quality assurance of radiological equipment and radiation dose monitoring. Let's welcome Mr. Adson Leung.
Thank you very much.
Good afternoon, everyone. I am Adson Leung. I am a certified medical physicist on imaging physics and radiotherapy physics. Today, I'm very glad to be able to share with all of you on the topics on radiation protection for pediatric imaging. Infants and children deserve special consideration when undergoing X-ray examinations, as they are characterized with higher radio sensitivity and longer life expectancy. Fetus, neonate, and young children have rapid growth with numerous mitotic cells, which are more sensitive to radiation during particular cell division cycles. Also, due to their small body size, radiosensitive organs could be more packed. Thus, even if we have our X-ray field well collimated, more tissues may have to be exposed to radiation, either from direct radiation or scattered radiation. According to the ICRP publication 103, 3 basic principles could be applied to enhance radiation protections. For justification, we justify the need for the exam. We justify if replacement available instead of radiation for such exam, and we justify if such use of radiation will produce more good than harm to the patient or the population. After the use was justified, then we optimize it using the ALARA principles, which is the as low as reasonably achievable concepts. We minimize the radiation dose while maintaining an acceptable result fulfilling the purpose of the exam. Also, dose limit for public and occupation were set to prevent overexposure, resulting in any radiation-induced health effects. To achieve the ALARA principle in imaging, we could optimize our exposure technique factors or protocols. We could also conduct regular patient dose survey and review. By performing individual patient dose monitoring, especially for patients undergoing high-dose examination, such as interventional cardiac procedures, and applying appropriate shielding to protect those radiosensitive organs, such as our lenses or goggles. I'm sure a lot of you have already been very experienced in optimizing your imaging technique factors and protocols, also with the aid of the modern dose reduction solution provided by various vendors. To further reduce patient dose, here I have shown some general tips for promoting radiation protection to patients who undergo general radiography, interventional procedures, and CT, which you may have a look when you have time. After the imaging protocol have been set up and optimized, a patient dose survey or review have to be conducted regularly to ensure the practice will align for most standard patients. The survey should ideally be done for each modality and each procedures, in which the data will preferably to be recorded automatically. Apart from conducting the survey in a certain time interval, close monitoring on the dose trend when new equipment or a change of practice is employed would also be needed. However, for medically exposed persons, dose limit is no longer applicable, as we have already justified that such radiation dose could do more good than harm to the patient. So, without a limit, how should we compare our patient dose data with? In diagnostic radiology, instead of a dose limit, the diagnostic reference level was used for an advisory purpose. It is initially proposed by the International Commissioning of Radiological Protection, the ICRP, back in the 90s. It served the purpose to identify if a consistently high or low dose was employed on a particular procedure on standard-sized patients. The DLL was typically selected as the 75th percentile of the dose distribution from a large-scale dose survey on a selected imaging procedures. It should be beared in mind that the DLL value is not designed for individual dose monitoring, but by comparing the DLL with the mean values of a group of patient doses. A large-scale dose survey could be performed nationally or regionally, resulting in the national DLL, or it could be performed to define the local DLL within a single hospital or cross-center cooperation if the case number was limited. You may find pediatric-related DLL from the following sources, which the European Guidelines on DLLs for Pediatric Imaging was published on the year 2016, which include reference value from 36 European countries and provide advices on how to establish the DLL for your center. However, you may not be able to find all DLL values for every single procedure. It is because there are some challenges we may or may not be able to overcome. The first challenge we may encounter with is the great size variation among the pediatric patient population. The size of an adult could possibly be varying by a factor of 4. However, for pediatric patients, the size may vary by factors of 300s. Thus, it is not applicable to be summarizing the whole pediatric group into a single pediatric standard patients as in the DLL for adult does. Although it seems that this could easily be solved by patient grouping. Although age is a good factor for categorization, but considering the weight of pediatric patient could also vary among the same age group. Weight is thus always be recommended as another factors for patient grouping. However, these arise another issues. Since we divide the pediatric patient into a number of groups, we have to establish a DLL for each of these groups. While there might be some procedures are with very limited case numbers in a particular age or in a particular weight group, so making it even more difficult to establish its own dose distribution and dose the DLL. In 2015, Javinen et al. Have introduced the DLL curve concepts, which was also recommended in the European Guideline on DLLs for pediatric imaging. It only requires 20 sampling for each of the patient group instead of hundreds. Once established, a random survey of at least 10 patients can be adopted, and a corresponding dose curve can be plotted. If the plot is below the DLL curve, then it is considered that the imaging practice was consistent as it is optimized. However, one should bear in mind that the DLL curve could only be used if it is clearly indicated that there is a clear relationship between the selected DLL dose parameters and the patient grouping parameters. DLL are suggested to be established with those parameters which are readily available. Here shows a list of the recommended parameters for different modalities. For general radiography, we will be using the DAPs and the entrance skin dose. For interventional radiology, we will be using the DAP as well, and also the interventional reference point dose, which is the IRP dose. The fluoroscopy time could also be used as one of the DLL parameters to show the complexity of the procedures. The number of images is also the same concept as the fluoroscopy time. For CT, we will be using the CTDI weighted or the CTDI volume, the DLP, which is the dose length product, and also SSDE, which is the size-specific dose estimate. The above dose parameters are all readily available from the imaging system itself, so their accuracy will be of highly concern. It is essential to carry out comprehensive quality assurance program to ensure the system consistency and also the accuracy of the dose parameters. These examples could be checking machine's exposure output constancy, collimation accuracy, and reported dose accuracy. When we come to the discussion of pediatric DRLs on general radiography, some may ask, is there really a need for setting up a DRL for such relatively low-dose procedures when comparing with CT and interventional radiology? As we have said, the DRL is not used for the sake of dose monitoring of a single exposure event. It is looking more macroscopically on the collective effective dose to the whole pediatric populations. Taking an example of pediatric chest radiography, it is relatively low dose when comparing to CT and IR. However, it is, on the other hand, also one of the most frequent pediatric examinations, which may result in a high collective effective dose to the pediatric populations. And that is why there is a need to establish the DRL for general radiography. Now, even for the comparatively low-dose general radiography required to set up a DRL, there should be no doubt that there is a high need for setting up a pediatric DRL for interventional radiology procedures, as it involves the use of high radiation doses. However, DRL for IR procedures is always considered to be the most challenging to be established. Conventionally, it was thought that the limited number of IL cases within the pediatric age group was one of the obstacles for DRL setup. However, this could now possibly be solved by using the DRL curve approach as discussed previously. While the second and the most challenging obstacles encountered in IR-DRL is the diverse dose distribution within the patient group, especially observed in interventional cardiology procedures. This is due to the maturity of the patients, procedure complexity, which may involve a lot of case-based decisions, and also there might be several techniques available for carrying out the same procedures, thus introducing further diversity in the dose distribution in interventional cardiac procedures. There is by far no national DRL have been set up for IC procedures, and only very limited studies was accounting for the issues. So, before more studies and data are available on the feasibility of defining IR-DRLs, individual patient dose monitoring plays the main role on preventing radiation-induced deterministic effects, and also estimation of the risk of developing stochastic effects. For evaluation of the risk of stochastic effects, the patient organ dose and the effective dose data were required. To estimate the effective dose of an individual undergoing IR procedures, one could use the dose conversion coefficient methods. These conversion coefficients will be multiplying with the total DAP of the procedures, giving rise to a quick, easy, but rough estimation of the individual effective dose. These coefficients could be obtained from international reports and literature as shown below or derived locally. Another approach would be the application of dose estimation software. The one shown above was one of these software named as PCX-MC 2.0, equipped with Monte Carlo dose simulation algorithm to drive the estimation of patient organ dose, thus giving rise to the individual effective doses. These kind of software might be time-consuming according to the PC power you have, but it could be more accurate than that we have obtained from using the conversion coefficient methods. In the period of 2016, we have cooperated with the hospital cardiologists for a study on comparing the effective dose estimated by using the Monte Carlo simulation software with the dose calculated by using locally derived conversion coefficients or literature-quoted conversion coefficients. Pediatric patients aged from 2.5 to 19 years old were included in the study. relevant patient data were acquired manually and from the examination report, which was then input to the dose estimation software for calculation. Below is the two set of conversion coefficient used in the study. The set on the top was derived locally in our hospital, while the bottom set was quoted from the literature. The results for two age groups of patients represented here. The bar in blue represented the dose estimated from the MC software. The red bar is from the local conversion coefficients, and the green bar is the literature quoted coefficient. From the results, we could see that those estimated by locally derived conversion coefficients were more close to that estimated by Monte Carlo simulation, but still, it bears a maximum of 35% difference between the two. Using factors from other studies may even be deviated up to a 60% error. This is because the patient size, projection angles, exposure parameters, or tube filtration could be very different between center to center, not to say from country to country. Those users must be aware of this potential inaccuracy when simple conversion method is employed. Another modality concerned with the use of high radiation dose is computed tomography. Conventionally, CTDI volume and dose length products are selected as the DLL parameters for CT. These two were calibrated on standard CTDI head phantom and CTDI abdomen phantom as shown on the right. It stays good if using on adults, as most of their size do not vary significantly. But if we consider two pediatric patients who undergo a CT exam with the same CTDI and DLP, the one who is smaller in size will be experiencing a higher absorbed dose due to his or her smaller volume. Those CTDI fail to encounter the varying patient size of pediatric patients. To account for this, size-specific dose estimate was introduced by AAPM and ICRU, which they first convert the patient into a circular volume with an effective diameter from their elliptical body, which is then corresponding to a unique conversion factor applying onto the CTDI volume values. This value, with the consideration of the body size of the patient, is one step closer to the real patient dose than CTDI volume and DLP does. However, calculation of SSDE would become more complicated when dose reduction technique such as tube current modulation is applied. This required the calculation to be done in a slice-to-slice basis, thus raising the needs of an automatic computerized calculation software. An automatic patient dose management system should be capable to track the patient demographic data, scanning equipment, relevant dose parameters, and exposure technique factors. They are already available in the DICOM header and could be easy to be extracted. What is valuable for a dose management system is its ability of organ dose or effective dose estimation and further statistical analysis for dose benchmarking, in other words, the DLL. Such dose management system is now commercially available by various vendors. The software shown on screen is one of the examples of the available software. It is capable to record all dose data automatically and plot the dose distribution with regards on the selected dose parameters and patient groupings. Here show the dose distribution of a particular CT exams, where the maximum DLL was set as the 75th percentile of the distribution. One could see that the distribution here is quite diverse. There should be some room of improvement in optimizing this protocol or practice. Apart from statistical analysis, it may also serve as a calculation engine for dose estimation. For CT, it could encounter the calculation of slice-to-slice spaces SSDE. Besides, one of the most valuable functions of this software, which we are showing on screen now, is its capability in estimating the patient organ dose and effective dose from CT scan. The software will acquire all the CT images from the PAC system and perform Monte Carlo simulation for each scanning event on a patient-sized measured humanoid phantom. Thus, we could gain more dose information to deduce their relationship with any deterministic effects. Another valuable function this software could provide us is you may change the CT exposure technique factors in the software and observe on how this would impact on the patient dose. This gives you a hand on the goal for protocol optimization. But one should bear in mind that careful commissioning and acceptance of such dose estimation function shall be performed in order to understand the underlying deviation between the estimated organ dose with the actual measured organ dose by using TLD chips placed in a physical humanoid phantom. By our experience, it is very usual to observe an error of more than 20 to 30% between the estimated dose with the actual measured dose. But such quick estimation could still serve a good purpose, especially for cases of such as unexpected pregnancy, which the patient parents, the patient herself, will be very keen on knowing the dose to the fetus or to their reproductive organs. The Monte Carlo dose simulation is only available for CT, while for the IR procedures, the software could now provide it with a skin dose map by using model-based calculation. Thus, it is capable for us to foresee if there will be any skin effect will be resulted from the IR procedures onto the patients. Here show the dose distribution with the DLL value displayed, which are namely the minimum DLL, average DLL, and maximum DLL. Most of our discussion above seems to be more concentrated onto maximum DLL, as we are more afraid or more interested on bringing any harmful radiation health effect to our patients by using unnecessarily high radiation doses. However, we should also be considered the establishment of the minimum DLL, since if not enough radiation dose were used to create the X-ray images, the outcome images may be too noisy and that some valuable diagnostic information could be lost, which the patient may need to undergo a re-examination and those receiving extra radiation doses and violating the ALARA principle. The setup of minimum DLL will be used to review those cases which the dose were below the line and investigate on why such low dose is employed for the case. If it is observed that there is consistently a group of images with radiation dose below the minimum DLL, while it could still providing adequate diagnostic information, one should consider there seems to be a large room for protocol optimization. To conclude, children deserve special consideration when undergoing X-ray examinations. Establishing local DLLs could provide standards for careful monitoring and regular review of pediatric doses. In return, further optimization of the scanning protocols and ultimately reducing patient doses. And thank you very much for your attention. Thank you.
Thank you, Adson. I'm sure everyone finds Adson's presentation easy to comprehend, yet very informative. I will leave the questions to the end after the second presentation. Let's move to our second presentation, which is ultrasound computer-aided diagnosis of thyroid cancer. The speaker is Professor Micahel. Professor Yong is a diagnostic radiographer by training. He is the professor as well as the associate head of the Department of Health Technology and Informatics of the Hong Kong Polytechnic University. He is also the president of the Hong Kong College of Radiographers and Radiation Therapists. Professor Ying's research interest is in head and neck and vascular ultrasound. He has published over 130 articles in peer-reviewed journals and delivered over 100 presentations in conferences and meetings. In an independent study in 2016, he was ranked among the top 10 most impactful medical radiation scientists in research in the world. Let's pass the time to Professor Michael Ying.
Good afternoon, everyone. First of all, I would like to thank Mr. Lau San-ren for inviting me to deliver this lecture. Today, my presentation is on ultrasound computer-aided diagnosis of thyroid cancer. My lecture will be divided into 4 parts. First, I will give a background about thyroid cancer. After that, I will introduce the thyroid ultrasound and the thyroid imaging reporting and data system. Lastly, I will introduce 4 computer-aided diagnosis techniques. First, for thyroid cancer, thyroid nodules are common and have a malignancy risk rate of about 5 to 15%. And the incidence of thyroid cancer is rising worldwide in the past years, from 95,000 cases in 1990 to about 255,000 cases in 2017. And the number of thyroid cancer deaths also increased from 22,000 deaths in 1990 to 41,000 deaths in 2017. And females are more common to have thyroid cancer than males. The increased incidence of thyroid cancer may be related to the improved diagnostic technology so that thyroid cancer is more easily and accurately detected, and also the implementation of various health screening programs in some countries. Accurate diagnosis of thyroid cancer is crucial for the patients because it provides timely treatment to the patient and increase the patient's survival. It can also avoid overdiagnosis and overtreatment of patients with thyroid nodule, because overtreatment can lead to long-term thyroid replacement therapy, and the thyroidectomy may have a risk of post-surgical complications such as hypoparathyroidism and as well as vocal cord paralysis. Thyroid cancer diagnosis is commonly made by medical imaging, for example, using ultrasound, as well as fine needle aspiration cytology, FNAC. According to the American Thyroid Association guidelines for evaluation of thyroid nodule and cancer, thyroid ultrasound is used to guide clinicians in the selection of the most suspicious nodules for FNAC. Thyroid ultrasound. In thyroid ultrasound, there are different ultrasound features that can be used to differentiate malignant and benign thyroid nodules. And some common ultrasound features that can help us in identifying malignant thyroid nodules include the shape. For malignant nodules, the shape of the nodule is usually taller than the Y, and the border is usually irregular, and the malignant nodules tends to be marked hypoechoic and demonstrate calcification, in particularly if the nodules has microcalcification that is highly suspicious for papillary thyroid cancer. And for benign nodules, the spongiform appearance and as well as the nodule which is oval or round in shape are more likely to be benign. Here are two examples of malignant thyroid nodule. This nodule, you can see that it is the height is longer than the width, so it is the taller than wide appearance, and also the nodule is marked hypoechoic when compared to the surrounding thyroid parenchyma, and the boundary, the border of the nodule is irregular. And the nodule also demonstrates multiple microcalcifications, which appears as echogenic foci within the nodule. And subsequent fine needle aspiration cytology proves that this nodule is malignant. Another example of malignant nodule is here is the nodules. So you can see the boundary is irregular and not very clear. And also there are multiple echogenic foci within the nodule, which are microcalcification. And some calcification is even dense enough that it demonstrates the acoustic shadowing. These are another example. It shows the benign thyroid nodules. So this is the thyroid nodule. This is a transverse scan showing the thyroid, and this is the thyroid nodule. And you can see the thyroid nodule. Within it, there are some echogenic lines, echogenic area, and also multiple hypoechoic area. This is a typical spongiform appearance, and it is a benign nodule. Another example of benign nodule is it is a hypoechoic, and the border is well defined, and the shape of the nodule is oval in shape. So this is a benign nodule, which is proven by subsequent FNAC. Next is the thyroid imaging reporting and the data system, the THYRAX. The THYRAX is the thyroid malignancy risk classification guideline that are designed to assist with categorizing risk of malignancy based on several predictive ultrasound features of thyroid nodule. And there are some commonly used THYRAX as listed here. For example, the American College of Radiology, the ACL, which is the first THYRAX that derived by the ACL. And there are also the ATA, and as well as the EU, and also the Korean Society of Thyroid Radiology THYRAX. For example, in the ACL THYRAX, it classifies the different ultrasound features of the nodule into different categories. There are 5 categories: the composition, echogenicity, shape, margin, and the presence or absence of echogenic foci within the nodules. For each category, there are different features. For example, in terms of the composition, from whether the nodule is cystic or almost completely cystic, to solid, to or almost completely solid. So for each appearance, it assigns for a particular point. Similarly, for echogenicity, shape, margins, and echogenic foci, they also have different ultrasound features that represent different points. And after assessing the thyroid nodules with these 5 categories, so it will be able to have a summation of the points from each category, and then to determine, and then we can use this summated form as a summation of the points to determine the THYRAX grades. For example, here, if the thyroid nodules altogether the point is 0, then it is likely to be benign and the THYRAX rating is 1. However, if the summation of the points of the nodules is 7 points or higher, then that means the thyroid rating is 5, and it is highly suspicious of malignancy. So from that, okay, we can able to determine or give a suggestion of the suspicion of malignancy of the thyroid nodule. And in the ACR ThyREX, it also can provide subsequent patient management based on the thyroid rating. For example, if it is thyroid rating of 1 or 2, that suggests that no FNA of the nodule is needed, and the patient will just need to have the follow-up. And for rating 3 to 5, it depends on the size of the nodule. If it is a smaller in size, then it suggests to be follow-up. And if it is larger than a particular cutoff, then these nodules will require FNA. Next is the computer-aided diagnosis techniques. The ultrasound computer-aided diagnosis, the CAD, of thyroid nodule has 2 main approaches. The first one is computer-aided data classification for malignancy risk stratification. So it is primarily based on classification of the data. And another one is a computer-aided image analysis for malignancy risk stratification. And for this, it will analyze the images, the ultrasound images, in order to come up with a risk stratification. And this CAD in ultrasound thyroid diagnosis aims to improve the diagnostic reliability and accuracy. In the next few slides, I will introduce 4 CAD techniques for ultrasound diagnosis of thyroid cancer. The first one is developed by Choi and his team in 2015. It is a web-based malignancy risk estimation for thyroid nodule ultrasound examination. It is an open access online data classification system, and here is the website. And the data that we put in is from the operator who subjectively interpret the ultrasound image and then determine the ultrasound features, and then input the data into the online data form. And this is the paper that they published about this web-based estimation system. Here is an example. So when you go to the web page, you will be able to see this data form for you to fill in. For example, here, this is the ultrasound image. And I, as an operator, for example, then I will assess the ultrasound features of the nodule. This is the nodule. And in the ultrasound examination, it is common that we measure the size of the nodule. So here, after the measurement, we notice that the size of the diameter of the nodule is 1.2 centimeters. After that, from the ultrasound features, from the ultrasound image, I noticed that the nodule appears solid. And also, it is taller than wide. And the margin, the boundary, the border of the nodule is speculated. It is irregular. Okay, it is irregular. So it means speculated. And it is markedly hypoechoic when compared to the adjacent thyroid parenchyma. Also, it has microcalcification. Because in the study, in this image, there is no information about the stiffness of the thyroid nodule because there's no elastography has been done in this patient. So I can leave this section blank, and then I can click submit. And the web-based system will be able to generate a risk stratification of malignancy based on different ThyREX. And in this case, you can see that the malignancy risk of the nodule is relatively high, about over 97% to be malignant. And also in the Korean and the ATA guidelines, the THYREX, it is high suspicion. And the recommendation for this nodule is the doctor need to biopsy the nodules. Another example here you can see using the web-based system is, for example, in this case, in this nodule, the size is 1.3 centimeter, and it is predominantly solid, and the shape is oval shape, and the margin is smooth and round, and the echogenicity is hypoechoic, because in some area you can see that it is slightly isoechoic when compared to the surrounding thyroparenchyma. And there's no calcification, and again, no stiffness information of the nodule. And then if we click submit, then for this nodule, the malignancy risk is relatively lower. So, and in the Korean THYREX, it is low suspicion, and for the ATA guidelines, it is intermediate suspicions, and also other THYREX, it also demonstrates a low percentage of malignancy risk. And in some THYREX, it suggests the follow-up, but in some case, in some THYREX, it may still require the biopsy. It may suggest the biopsy. So, and eventually, subsequently, this nodule turn out to be a benign nodule. So therefore, in this system, it can easily and systematically provide a data form for the operator to fill in the information of the ultrasound features of the nodule in order to come up with a risk stratification. So this scoring system show a good performance in a validation test in the study. And this web-based malignancy risk estimation can provide a simple and reliable scoring system for ultrasound assessment of thyroid nodules. Another technique that I would like to introduce is the S-Detect. The S-Detect is a CAD system for ultrasound malignancy risk stratification of thyroid nodule. It is a deep learning-based CAD system, and it is an inbuilt software in ultrasound system of a particular company. And it provides a semi-automated segmentation of thyroid nodule in ultrasound image. So for example, this is a transverse scan showing a thyroid nodule, and this is the thyroid gland. So during the ultrasound examination using the ultrasound unit, once the image is obtained, and then in the ultrasound system, then we can press the button of S-Detect, and then it will come into this S-Detect platform. And the operator will need to use the square here, the software, to outline the region of interest, to give the system, the software, to know that what is the boundary of the region of interest, that is the nodule. After that, the system will give a automatic segmentation of the nodule, and there are different choices for the operator to choose which option, which segmentation is actually best fit to the actual order of the nodule. For example, among these four options, this segmentation seems to be the best match of the nodules. Besides, the operator can also edit the contour of the segmentation in order to make adjustment to better outline the contour of the nodule. Or the operator can also use manual contouring to contour and outline the boundary of the nodule in order to get a better result. So after contouring, either you use the automatic segmentation or you use the manual contouring, and the system will be able to give a possible diagnosis of the nodule. In this case, it is possibly benign. And the system will also give information about the ultrasound features of the thyroid nodule. For example, the system considers that the nodule is solid, it is hyperechoic or isoechoic, ill-defined, etc., and the oval to round in shape. So within a few seconds, including the contouring, it will be able to give the results. In the previous study using the S-detect, it found that S-detect actually gives a higher accuracy when compared to less experienced radiologists. And also it gives a higher specificity and higher positive predictive value than the less experienced radiologists. However, for experienced radiologists, the accuracy in the diagnosis is more accurate than the S-detect. Similarly, the sensitivity, the specificity, positive predictive value, and the negative predictive value are all higher for the experienced radiologists than the S-detect. And so therefore, S-detect could help less experienced radiologists in improving their diagnostic accuracy. However, it has limited clinical value to experienced radiologists because experienced radiologists actually can perform better than the S-detect. And the S-detect could be an additional diagnostic method for the ultrasound assessment of thyroid nodule and improve the diagnostic performance of less experienced radiologists. Another computer-aided diagnostic technique that I would like to introduce is the MCAT-UT. The MCAT-UT is a CE and US FDA approved CAT program for ultrasound diagnosis of thyroid cancer. It analyzes archived ultrasound images in computer workstation. So basically, the MCAT-UT is actually come with a USB drive, a USB flash disk, and then you just need to put into a computer workstation and then run the program and load the images into the MCAT software, and you can perform the analysis. The MCAT-UT uses the statistical pattern recognition and quantification method to analyze the ultrasound image. It provides automated segmentation of thyroid nodules in the ultrasound image. Here is an example. So after we load the images into the MCAT, and the MCAT will automatically outline and segment the boundary of the nodule. Similar to the S-detect, the operator can adjust the contouring, or the operator can choose to manually outline the boundary of the nodule for the analysis. Once the boundary of the nodule is outlined, then the software will automatically give an impression of the ultrasound features of the nodule. For example, the size of nodules and the echogenicity, the homogeneity, and also whether there is hypoechoic area, for example, any cystic component, or whether the nodule is spongiform, and the regularity of the margin of the nodules. All these features will be presented here. And also the nodules, whether it is benign or malignant, will also be determined by the software. So the risk of malignancy of the nodules will be assessed. and then different outcomes according to the different TAREX will also be demonstrated. And system will also provide recommendation for patients management according to the ACR guidelines. So as in this case, the nodules tends to have a lower risk of malignancy. So the system recommend the patients to have a follow-up examination rather than FNAC. And this is another example. It shows another nodule. And in this case, the risk of malignancy of the nodule is relatively higher. And it is in most of the TAREX, it also suggests that this nodule is highly suspicious of malignancy. And the ACR is also recommended that FNAC should be done on the patient. So therefore, this software system allows assessment of the ultrasound image and to give malignancy risk stratification. Previous study have been working on this MCAT software in assessing thyroid nodules. However, different results of the best performed TAREX were reported in previous study, including the Radiological study using the ATA and the LUT study using the Korean Society of Radiology. And also our previous study also used this MCAT, and the best performed TAREX is the ATA. And different results from different study could be due to the different sample size and also the different quality of the images used in the study, leading to these different results. However, one common finding from these different results, from this different study, is you can see that the sensitivity is higher than the specificity, okay, for all the different results. It is clinically, it is important to have a high sensitivity for the CAT system, because for the clinician, they would not like to miss any cancer patients, so that they put these patients at risk if they miss a positive case. So therefore, a high sensitivity is crucial for any CAT system. However, the low specificity will also leading to another clinical problem is patients who are having benign thyroid nodule will also be having thyroidectomy, and that will put them into a risk of lifelong thyroid replacement therapy, and also they have a higher risk of post-surgical complications. So it is still of a dilemma in the clinical practice of thyroid cancer diagnosis. And in LUT study, the clinicians, it also demonstrated that if the clinician refers to the MCAT UT results, the specificity will be able to increase from 55% to 85%, and the accuracy will be increased from 82% and 91%. So with the use of MCAT, it can able to help to improve the specificity and accuracy. And so therefore, MCAT UT can help clinician in improving the diagnostic performance. And because MCAT UT is compatible with the images from different ultrasound systems, so no matter whether you use the different ultrasound images from different systems, the MCAT will be able to process the image. So therefore, it allows CAD to be performed in different hospitals and clinics. The last computer-aided diagnosis technique is on the assessment of color Doppler ultrasound image. According to an international guidelines, thyroid nodules with increased central vascularity on Doppler ultrasound is indicated for biopsy. Here you can see a malignant nodules. So here you can see at the center, the vascularity is substantial. Okay, is substantial central vascularity. And when compared to the benign nodule here, the nodules tend to have peripheral vascularity, where the center do not have any vascularity. So therefore, because of this background, our research team developed an algorithm using the MATLAB to segment and quantify the central and peripheral vascularity of the thyroid nodule. And in our study, we find that by combining the regional vascular assessment with the grayscale ultrasound features, it actually helped to improve the diagnostic accuracy from 58.6% to 79.3%. Let's have a look how this algorithm works in doing regional segmentation. First of all, we have a Doppler ultrasound image, and we need to manually outline the thyroid nodule, that is the region of interest. After that, we will then put this image into the MATLAB with the algorithm, with our algorithm, and then the algorithm will automatically segment the region of interest, and at the same time, it will also provide another image that with all the grayscale pixel being removed, leaving only the color pixel. And after that, this algorithm will automatically perform the segmentations of central and peripheral region of the nodule after we define a certain offset. So with this, the offset is meaning that how much of the area of the peripheral region will need to be segmented from the nodule. So with that, the algorithm will automatically segment the peripheral region and the central region. After the segmentation, the algorithm will count the total number of pixels within this region of interest, and as well as the total number of color pixels within the region of interest to determine the vascular index of the peripheral region of the nodule by having the ratio between the total number of pixels and the number of color pixels within the region of interest. And similarly for the VI of the central region, so the algorithm will count the total number of pixels within the region of interest and as well as the number of color pixels. And then the ratio between the two will be the VI of the central vascularity. And in fact, our algorithm is not only used for the application of ultrasound assessment of the thyroid nodules, it also used in the ultrasound assessment of the lymph nodes. And it proven that the quantification using this computer-aided assessment method can actually help in the assessment and differential diagnosis of different types of lymph nodes. Besides that, we also use this algorithm and software in ultrasound assessment of, for example, the plantar fasciitis, and also to assess the patients with chronic plantar fasciitis, and as well as using it to assess the tendon vascularity. So to conclude, computer-aided diagnosis is useful adjunct in ultrasound diagnosis of thyroid cancer. It is particularly useful for less experienced clinicians in clinical decision-making. However, continued research and development of the CAT are still needed to further improve its diagnostic performance. Finally, I would like to thank my research collaborator, Dr. Shirley Liu, Dr. Sina Low, Professor Andrew Ahuja, Professor Danny Chang and his research team, and also my research student and also my undergraduate student for the help in the research. And also I would like to thank the funding support from the Hong Kong Polytechnic University. And these are the references for this presentation. And that is the end of my presentation. And thank you for your attention.
Thank you so much, Dr. Michael Ying, for his very informative talk. And it's exciting to note that Dr. Ying is also actively involved in the developing CAD for their teams. And we hope that there will be more good news on that. So it's now the Q&A time. I will be concentrating on looking at the chat room or the Q&A room to see if there's any questions. And I suppose the panelist guests can just turn on their mic and ask questions, isn't it?
I have a question first.
Yes, yeah.
I have a question for in Mr. Adson Lin. And also I have a question for Professor Micahel later. The first of my question for Adson.
Yes.
You have in Hong Kong, you have a guideline parameter for DRL. You have a guideline, society have a guideline for in your society or your country, MOS have a guideline DRL parameter for on hospital, and who moderator or who control or who check in you correct or incorrect DRL parameter. The first question for Adson.
So do you mean, do we have any guidelines for determining which is correct or incorrect parameters for the DRLs? Okay.
Yeah, correct. Facility for X-ray and intervention X-ray.
In Hong Kong, we do not have any regulations regarding on the use of DRL, but we are now have purchased a automatic radiation dose management system so that we can have more data we can collect and then trying to establish a local DRL so that we can have some parameters for our radiographers or radiologists to reference to so that we can try to optimize our protocols, our exposure technique factors so that we can benefit our patients with a lower dose exposures.
Yes. I see. I don't know in how about in Malaysia. I'll share for everybody later, because in Vietnam it's not have it yet, and so, in how Indonesia, in Taiwan also, I think everybody's shared in you have a guideline or who in control, ability control in radiographer in you correct or incorrect. I need to in Taiwan and Indonesia and Malaysia and Macao, and so you share for everybody. In Taiwan.
Okay, hello. As for Malaysian, we just started our DRL for the Paediatric few months ago. We are in the process of collecting the data, but actually this one is the second round of the collecting data, because the first one is we are not enough data to conclude for the DRL, for national DRL. But for the general and fluoroscopy, we just started to collect the data, and very soon we're going to implement or we come up with our own national DRL. But the reference is still we are using as what the speaker is saying that most of it we are referring to the international ICRP guideline. Okay, thank you.
In Taiwan, how about in Taiwan?
Taiwan, we follow the guideline from the ASIA, and we have some limitation value for mammography and CT, but in other machine we don't have established any like guideline for this. Yeah.
What problem? What problem with you if you in your prefer and you correct? Okay, congratulations. But incorrect. How about with them? What with them? How about in Indonesia, Macau, Philippines?
Oh, Macau not yet start to do the DLL because you know the Macau just only the CT. It's a very small amount, but really the pediatric DLL is most important because the dose is very sensitive for the pediatric. So I agree all the country must do that.
Yeah. From Indonesia, no?
Yeah.
We will launch national DRL from the next Tuesday for diagnostic imaging. Yeah. So I think we can learn from other countries that's already established the value of the DRL. Yeah.
Philippines, not yet.
Yeah, we don't have a universal or nationwide DRL set for the country, but I know that for a specific institute, in their radiology, they are setting their own guidelines for radiation limit of radiation, pediatric radiation exposure.
Yes. Okay, thank you, Adson. The second question for Professor Micahel. I interact very great presentation from lecture. I don't call it presentation, I call it lecture from Professor Micahel. Oh, very good news. My question, the first question, how long you use a CAD system in software? How long you use? The first question. And the second, like you saw, how many millimeter is CAD can detect in nodule? How many millimeter? Like you saw in your PowerPoint, less 1.5 millimeters. We can no need. Sometimes we no need biopsy. And how CAD can help for you? How many millimeter? The minimum how many millimeter? And the third question, I show you in Doppler, ultrasound Doppler, in many color, how relationship with in CAD software, CAD system with in color Doppler. Invite Professor Micahel.
Okay, thank you for the questions. For your first question, basically for me as a researcher, I use the CAD in the for thyroid imaging I think is for about 4 or 5 years. I think clinically it is still not widely used, the CAD. It's because at least for the MCAT1, you still need to capture the images, and the images still need to be transferred to a computer workstation to perform the data analysis. Until recently, there's one ultrasound company that they have the SDTAT that they allow the assessment of the images right after the ultrasound scan. That means the doctors or the operator can directly, once get the images with the patients next to him or to her, then he or she can immediately perform the analysis, the SDTAT CAD analysis with the ultrasound unit. But I think in the future that will be the trend that more and more CAD, particularly for ultrasound, will be available and for the use. One point that I think we need to be understand that unlike the CT or MR images, ultrasound intrinsically that the image resolution may not be as good as the CT and MR. So therefore, in terms of the CT development, it is a little bit lag behind when compared to CT, MR, or maybe even mammography or X-ray imaging. For your second question, which is about the size of the nodule. For the size of the nodule, whether it is detected, it is purely based on the resolution of the ultrasound machines. Clinically, the ultrasound image that can detect the nodule can be as small as a few millimeter. Okay, a few millimeter of the thyroid nodule can be detected, as long as the image demonstrates the nodule. That means you can see the nodule on the ultrasound image, and then the CAT should be able to make an analysis of the nodules, because the operator will need to either using semi-automated or automated segmentation to outline the region of interest. As long as the region of interest has been outlined and confirmed by the operator, the CAD can make analysis. But of course, the smaller the nodules, that means the less information will be available for the CAD system to make the analysis. So therefore, the accuracy will be relatively low. Similarly, for FNAC, if the nodule is very small, the nodule may not be, we may not be able to get enough samples from the small nodule. So therefore, the range of undetermined FNAC result will be higher for smaller nodule. I hope I can answer your question. For your last question is
Doppler.
The color Doppler, right? So in terms of the color Doppler, the system that we developed can assess, actually is counting the number of the color pixel, regardless it is the red signals or the blue signal or whatever kind of color signal. Because the color is actually indicating the direction of the blood flow on Doppler ultrasound. So it is not directly related to whether it is benign, it is related to the direction. So the system itself will count the number of the color in order to determine the peripheral region, the VI, and as well as the central region, the VI, and then giving out an information about the vascular distribution of the nodules.
Yeah, thank you, Professor Michael. You really, I'm really ask you, some radiologist experience, like in your last slide, you tell in FCF, follow in some hospital, some clinic. I want to ask you, you are really, when you use the CAD system, the computer AI, how about do you think? How to help for you? Very good for you. You are if you are experienced, if you are a young radiologist. How about you? How do you think?
So your question is about how useful for the technology, the CAD, in helping the younger radiologists or inexperienced radiologists?
Yes. Okay. Young radiologists, young technology, or experienced or radiologists?
Basically, this technology can help the maybe inexperienced radiologists or younger technologists in giving a second opinion when they try to determine the nature or the diagnosis based on their experience. And then he or she will able to use the CAD to give them some additional information based on, for example, because the CAD will able to give information about the ultrasound features, for example, whether it is solid, whether the cystic component, whether the boundary is irregular, or speculated, etc. So this information can actually help the experienced radiologist or the technologist that when they look at the images, look at the nodules, they may the system may able to point out some features that they may miss during their interpretation. So this can actually help in improving their accuracy in interpreting the images.
Yeah. Okay, thank you, Professor Michael. Very good.
Any other question from the panelists? At the moment, I see no question from the audience yet. So will any panelists will raise your question?
I think from Indonesia, you platform Yong and Paediatric platform Yong. If you have a question, please copy to in Yong platform in 1000 men Yong platform. Copy to here.
I have a question about the ultrasound thyroid to the Michael. Michael,
yes, please.
I want to know about the FNA more than the AI system. I don't know if you have any data or not. In Hong Kong, mostly for FNA, the needle gauge. What is the needle gauge to use of the FNA in Hong Kong commonly?
It varies with different hospital, different practice, because nowadays not only the radiologists will perform the FNA of the thyroid nodule, but actually a lot of the thyroid surgeons, they perform their own thyroid ultrasound and also the FNAC by themselves. So it varies different. I'm sorry, I don't have a exact details information about what is the gauge that they use, but they vary quite a lot.
Okay, because the FNA is the final result for the patients, is the suspect for malignant, so it's the most important. Sometimes in the FNA, sometimes if you can fail the FNA and then we will need to repeat. So in Macau also have this problem. So we need to try to use the different gauge for the sampling, because the pathology department always say not enough samples, is no T-cell like that probe, and then the patient need to repeat. So I want to know about the gauge. But I don't know in Hong Kong you have any problems for the patient to repeat. The repeat FNA rate is high or not?
Yeah, this is also a problem in Hong Kong, as the rate of FNAC in determinant result is about 20%.
20%.
Yeah. So for those patients, so that is based on the literature. So for those patients that with FNAC in determinant result, usually they will be asked to have a repeated FNAC. And if the repeated FNAC is still indeterminate, then that will be depends on different practice in the hospital. Some hospital may be perform a prophylactic thyroidectomy to remove the surgery and then perform the histopathology of the nodules to confirm the nodules. And most of the time in histopathology, they will be able to find a determined diagnosis, because actually the nodule has been resected out and then perform the histopathology. Or in some center, they will be perform and wait and see policy that will be maybe follow up the patients. So it depends on the practice of the center. That will be also very strategy in managing the patient.
Yes. Okay. Okay. Thank you.
Yeah, that's a question for Adson. The question is, what is the best practice in communicating radiation risk for pediatric patients? You understand?
What we have been done in children's hospital is maybe we can produce some brochures which have included some information about the radiation doses to our patients, maybe how much radiation doses is actually a patient will be receiving when they are receiving a chest PA exposure or a CT scan, so that they can have a slight idea on the radiation doses comparing with like the environmental dose. Some of the radiation doses is so low that it is just multiple times of the environmental radiation doses they will be receiving in like a few days. So some of this information can try to reduce the anxiety of the patients or the patient parents. And we also know that there are some videos which are cartoons which can be shown to young patients so that they can take into account on what is actually going on in the examination and how this radiation will be reacting to our bodies, which will not induce any radiation harmful effects, which we have been seeing some of these videos, which they are very interesting, and our patients love to watch them. So this also helps to reduce their anxiety before they entering the examination room and make them happily to go through the entire process.
Oh, very nice. Maybe I'll continue with the question also to Adson. Apart from the Monte Carlo method, are there any other methods?
There's the most simplest way is if you have a physical humanoid phantom and also some TLD chips, it is a great method to verify the radiation doses to the organ dose, which we have been actually doing. Instead of just using the Monte Carlo methods, we're also measuring the dose with a humanoid phantom, because some of the times you may not be able to really ensure that the dose calculated by the software is true. So you have to have another third parties tools to ensure that at least the things you measured, or at least the things you calculated in software, is comparable to the reality.
Very good. Thank you. There's a question from a member, Sandra. Just now I communicate with her from the mobile. The question is to address to Professor Michael Yong. Is how difficult would it be if the thyroid is a multinodular lesion? Because just now what we saw is only a single nodule. Well, how difficult would it be multi-nodules? And plus, will it be even more difficult when some of the nodules are benign and some are malignant?
Thanks for the questions. And actually, this is why we need to perform the ultrasound, is to guide the doctors in choosing the most suspicious nodule for the FNAC. And in cases of patients with multiple nodules, then for the CD, we will then need to perform a CD on individual nodules and then to come up with a finding that the operator, with the help of the CD, in deciding which nodule is the most suspicious, and in order for the doctors to determine which nodule is going to be bouncing. So that means we need to perform multiple times.
Separately.
Separately.
So any other questions or from the panelists?
Can I have a follow-up question with,
Sure.
I think this is something that is related to the previous question to Sir Adson Liu. Yeah, so in the Philippines, national or government hospitals now have a resident medical physicist in the radiology. Now, I'd like to know, in case where in your country, what is the level or extent of the communication pathway between the radiographers and the medical physicists in terms of discussing about radiation protection and limit of exposure to pediatrics?
Do you mean the communication between medical physics and radiologists regarding on radiation protections or radiation doses towards the patients, or?
Yeah, medical physicists and radiographers or radiologic technologists.
Okay. Basically, what our medical physicist is doing in Hong Kong is majorly on the machine QAs, which we ensure the machines consistency on the exposures, the output, the image analysis. This is what we majorly doing. And the second, we will be working with radiographers is some studies on the radiation doses. And also when there are some queries from the patients regarding on how the radiation doses is actually deposited on them, which we will be mainly working it's sometimes like complaint from the patients that they're asking how much radiation they're receiving, and we're trying to solve that. This is one of the major things we are doing as well. So we sometimes also give talks to radiographers and radiologists in terms of some new techniques and also radiation doses related basis stuff. Like what we are doing in the DRLs is also one of the major projects we are working with, and we'll be reporting it so that all our colleagues will be keep on track, knowing that what is actually we have been doing and how our optimization is going with.
Yeah, thank you. I asked that because in the Philippines, there's still somehow overlapping roles with regards to communicating radiation protection and exposure to pediatric. We know that patients and parents of children are more aware about radiation and effects. So I asked that because whenever there would be parents who are questioning now, the radiographers or radtechs who will be handling the children for an exam. You mentioned earlier that there are means on how you provide learning materials to be watched or read by patients, right? So I wonder who prepares these materials in the radiology.
Majorly, we prepare together with the radiographers because some of the times, some of the terms which may be more accurate will be used by the radiographers. So we mainly prepare those information and we cooperate with the radiographers so that we can prepare something that is entirely readable by the patients, because some of the times the medical physicists use the terms which are so strange, so that the patient may not be really understand. So we cooperate together to give some information which is valuable towards our patient to reduce their anxiety and help them out throughout the patient's journeys.
Yeah, thank you. And my last question would be for Professor Micahel. We know that the use of AI or softwares that help us in the diagnosis of ultrasound images are helpful. I wonder if you have made mention about, since we know that these can all be operators dependent, have you discussed about the users' feedback about the ease of use, like the length of time, the turnout time, how fast and easy they can finish one diagnosis by using a particular CAD software? Thank you.
Yeah, thanks for the questions. At the moment, we did not perform such kind of study in terms of the users' satisfaction or users' perspective survey. That's all information. But however, in my experience in using for example, the SDNet, the MCAT, and also our own developed software program, the processing time actually is not too long. For example, for using the SDNet, once you got the image and then you perform the analysis, it's basically within 1 minute you will be able to get the result. And also for the MCAT, it's also once you load the image into the software program, you do the segmentations, and again within 1 minute you will be able to get the results. And similar for the our own development program. So basically, even from when I talk to my students, research assistant, how about their performance? How about the perceptions in using that sort of CAD program? They do have a very good experience in using that, and very easy to learn because the operation is actually quite straightforward.
Yeah, thank you, Professor Yong.
Yeah, that's the question for Adson from the Mr. Edward Wong. He's asking you, will you suggest developing a local conversion factor for departments to calculate the effective dose?
Thank you for the question. I think it will be a good practice to have such factors, but not for all procedures. I think it's mainly for those procedures which involve a long exposure time, like cardiac procedures, so that we can have a quick understand on how much effective dose is deposited to the patients. And because why we are doing the study I've mentioned in my presentation is because our cardiologists really want to know how much radiation dose is actually deposited towards their pediatric patients. And we cannot put TLD chips on every patient we have because it is too difficult and it may also be interrupting the procedures. So if we can proactively using some software-based simulation to get back the radiation dose after the procedures, and then develop your own local conversion factors, which will be a quick and effective way to know how much effective dose is actually deposited to the patient. Besides, why this is very important for using local conversion factors is because if you're using international journal, which it may be coming from European or American-sized patients, which are totally different with our maybe Chinese people or Asian peoples, the size, the body thickness, the weight, the height is totally different. So you may find that if you're using literature-coded conversion factors, the error you have when you calculate the effective dose will be like 60% difference. So it is good to have your own conversion factors, even not for a whole region, but using on your own cluster or own hospital, it may be better because there may be variation between procedures or how you perform your procedures.
So you also agree that that's a good way to go. So,
yes,
so how is Hong Kong doing actually?
Actually, we do not have create such conversion factors for every procedures, but in requests, like the cardiologists, they ask for such factors, then we will be producing one of these conversion factor for their own use.
Thank you. So any other questions from the panelists or members?
Hello, sorry.
Yes, please.
Yeah. For the CAD or artificial intelligence in Hong Kong, how about the radiologists? Is it okay for radiologists for this? Or there is any regulation for using artificial intelligence in radiology?
Okay, thank you for the question. At the moment in Hong Kong, not all the imaging modalities will be using, I mean, particularly in a major public hospital organization, the hospital body, not all the imaging modality will use the CAD. As far as I know, they're using a kind of CAD, the AI, for chest imaging in triaging urgent chest X-ray for reporting. Okay, this is a relatively more major applications at this moment in terms of the AI. And for the other applications, including those I mentioned here, there is actually depends on different radiologists or different centers practice whether they will choose this to use in their practice. But there is actually at the moment there's no particular regulations or guidelines, as far as I know. Maybe other Hong Kong colleagues can supplement if I mistaken. There's no such regulations in doing that, in using the AI. So the only major one that I'm aware is the application of the AI in the chest X-ray imaging.
Okay, thank you.
I hope this answers your question.
Yeah, thank you.
Any other questions? Yeah, for the interest of time, maybe we allow a little more time. Otherwise, well, we'll be finishing this presentation Q&A part.
I think enough.
Okay, so I'll pass the time back to Peachy then.
The message, say hi, say bye, goodbye, from Nelson.
Yeah, thank you, session moderator, Mr. Bobby Chiu. Now, I would like to call again the president of Hong Kong Radiographers Association, President Nelson Wan, for his closing message.
Okay, thank you, Peachy. Thank you very much for Mr. Leung and Professor Yong for their very fruitful lecture this afternoon. And may I take this opportunity to thank the VT Healthcare and Bayer Vietnam for organizing and the technical support for this program in order to make this event success. Of course, including all of you. Without you, we are not here to make this program success. So once again, thank you very much for all of you.
Thank you very much, President Wan Shu Nelson. You know, we are all excited to know about the next CPD Asia, right? Its schedule and the Southeast Asia Radiographers Conference. So to address now an invitation and to tell us more about these exciting events, let us all welcome President of Vietnam Association of Radiologic Technologists, President Thyroid.
Yeah, thank you. Thank you so much. I want to good afternoon, everybody, my friend, all my friend. Today, I see not only in YouTube, also in Facebook, also have a lot of people from in YouTube, from Facebook, in any country in the world. In today, we have two brief presentation, a lot information. I think I want to share with every audience. Want to review again. You can go to in YouTube and you search VART. You can review again because a lot of information in short time we don't remember. Okay, please search VART in YouTube for review again. And I want to share my screen. Okay, want to share my screen. The next month, 27, is Sunday morning in Vietnam, host Southeast Asia and Asia Open Asia Conference, and to get with in the number 6 Asia CPD. Introduce with everybody, and we have a 3 room. Room 1 for imaging, radiology technologies. Room 2, nuclear medicine. Room 3, radiation therapy. And next week, I will post I send to in any country for in some president and IT. You share for your member in a registration link for your registration link. You please remember you link your registration for in your correct in your room. Number 1 in radiology imaging. Number 2, room 2 in nuclear medicine. Number 3, radiation therapy. And specialists, I think that you are interactive program in 27 Sunday, June. I think I want to focus something. I not only invite upon some new technique. We have a new speaker have a new technique. Especially, we invited Mr. Steven. He is not in radiologist. He is not in radiologist. He is not in radiographer. He is a CEO Microsoft in USA 30 years. Now still working. Now he research. He make one company in AI or in radiology. We invited him share some experience when he researching. He make something about AI in radiology. And we also have some new technologies in MRI and MRI in protocol, new protocol, and new in AI in cardiac, and some AI and new technologies also in nuclear medicine. Also, we also invited in Thailand, in Taiwan also. In radiotherapy, I'm also invited in specialists specialist in radiotherapists in many countries in Asia. I think everybody, please support for us. In next week, we will post in poster and program. We will send to in your society and send to in Facebook and registration link in next week. Please support for us, free, everything free, everything free. And the last, I want to thank IT group in for Asia CPD. You are a silent IT group from Taiwan, Hong Kong, Indonesia, Philippines IT group. We are good cooperation. I think we next time we open more in Japan and Korea, more and more. We continue keep in touch with in IT group. I'm also thank you in Peachy Luna. You work hard. Thank you so much. Thank you everybody. See you everybody in 27 Sunday June. Okay, Peachy Luna, continue.
Thank you very much, VART President Van Lok. The VART will host the online 6th CPD in conjunction with the 7th Southeast Asia Radiographers Conference on June 27, 2021. And as we heard it right, the registration is free. So this is the first free Southeast Asia Radiographers Conference, so you never should miss that. So, and by August of this year, the Macao Radiologic Technologist Association will host the next Asia CPD. So again, from all of us, with all the participating presidents, we thank you, BT Healthcare Vietnam and Bayer Vietnam, our distinguished 2 expert speakers. We thank also everybody for your active participation, and congratulations to Hong Kong Radiographers Association and President Nelson Wan. We hope to meet you all again in the 6th online CPD platform for Asian Radiologic Technologists. This is CPD Asia. I am Peachy Luna saying good day, everyone, and thank you.
Okay, thank you very much all. Goodbye.
Goodbye. Thank you, everybody.
Thank you.
Bye.
Thank you so much.
See you next month.
Bye-bye.
All right. Thank you, everybody. Bye-bye.
Baik, demikian tadi. Bapak Ibu silakan bisa mengisi absen akhir. Terima kasih atas kehadirannya pada sore hari ini, dari siang hingga sore. Silakan mengisi absensi. Irma, masih setia? Bagaimana kabarnya?
Masih belum, menarik sekali ya.
Ya.
Topiknya. Dan tadi ada satu pertanyaan juga dari partisipan kita dari Indonesia. Jadi metode apakah yang digunakan selain Monte Carlo? Jadi juga sudah dibahas ya. Jadi kalau punya TLD sendiri lebih bagusnya langsung keluar hasilnya berapa dosis untuk pasiennya.
Ya. Dan kita juga tahu dari Bapak Ketum bahwa sepertinya hanya Indonesia yang sudah memiliki DRL ya, yang akan nanti di launching tanggal 25 depan, tanggal 25 Mei ini.
Ya,
25
itu
Mei
DRL 2021 berarti 2020 berarti ya, Beli ya?
2021 sepertinya, Ir.
Oh, 2021 ya, iya. 2021. Jadi sangat unik sekali ya. Jadi patut berbangga kita Radiographers Indonesia karena kita di Indonesia sangat update sekali ya tentang DRL ini. Jadi kita setiap tahun diupdate nilai DRL-nya. Padahal kalau di negara lain itu kita lihat ada yang 5 tahun, 4 tahun, tapi Bapeten sepertinya sangat gencar dan concern tentang dosis radiasi ini.
Iya, betul, Ir. Dan tadi juga kita ketahui bahwa negara lain seperti Malaysia, mereka bilang kita tidak punya nasional DRL, Filipina juga begitu, dan lain sebagainya. Jadi Bapak Ketum dengan PD kita akan mulai minggu depan. Betul sekali, tanggal 25 Pari akan tanda tangan komitmen untuk menjalankan DRL nasional yang sudah disepakati. Demikian informasi dari PP Pari. Mungkin dari rekan-rekan ada yang ingin berkomentar, kami akan buka untuk sesi diskusi dengan menghidupkan semua peserta bisa meng-unmute sendiri mikrofonnya. Silakan ingin menyampaikan sesuatu sembari kita closing sebentar lagi. Kami harapkan dari Mas Hidayat Sabarudin, jika masih ada dalam ruang Zoom kita, untuk dapat menutup sebentar lagi. Mas Hidayat, mohon dapat mengirimkan suaranya.
Ya, terima kasih, Bli. Masih mengikuti, Bli.
Luar biasa, terima kasih Mas Hidayat. Demikian tadi ya. Ya, dengan sumber daya yang kita miliki, jadi kita sudah melakukan relay, walaupun di awal itu dengan berbagai kendala, seperti misalnya gambar yang melengkung, betul sekali. Ada beberapa yang nanya, ini apa pakai action cam ngerekamnya dan lain sebagainya. Tidak, itulah yang ada saat ini di kami dan kami gunakan sepenuhnya. Nanti ke depan CPD yang lainnya dengan pengalaman relay yang lain nanti kita akan perbaiki sedikit demi sedikit. Bukan begitu ya, Mas Hidayat?
Ya, terima kasih atas effortnya, Beli Butuh. Sebelumnya saya sapa dulu rekan-rekan semuanya yang hadir dari seluruh Indonesia. Assalamualaikum warahmatullahi wabarakatuh. Ya, buat rekan-rekan Muslim, taqabbalallahu minna wa minkum, taqabbal ya karim, minal aidin wal faizin. Mohon maaf lahir dan batin atas nama pribadi, atas nama saya pribadi, atas nama sebagai pengurus juga mungkin ada kesalahan atau kehilafan selama ini. Mohon maaf.
Nggih, sami-sami Mas.
Matur. Dan untuk berikutnya tadi kita menanggapi apa yang sudah dilaksanakan pada sore hari ini, kegiatan kita menyebutnya Zoom Relay, yang merupakan salah satu upaya untuk mencoba sesuatu yang baru, dan ini juga sudah didiskusikan dengan tim ASEAN lainnya, dan Indonesia juga melakukan hal yang sama. Dan alhamdulillah mudah-mudahan dengan segala kekurangan dan kelebihannya ini bisa menjadi satu pengalaman penting. Walaupun sebenarnya kita sudah mencoba mengikuti cara relay yang benar menurut aturan Zoom, karena sebenarnya sudah ada aturan Zoom yang menurut relay, tapi beberapa kendala setelah kita mencoba simulasi semalam ternyata tidak smooth. Alhamdulillah hari ini lebih smooth daripada yang kita lakukan simulasi-simulasi sebelumnya. Mungkin saya hanya bisa menambahkan mengenai kegiatan tadi apa yang disampaikan oleh Pak Ketum terkait dengan DRL, dan ini sangat nyambung sekali bagi teman-teman atau rekan-rekan yang menginginkan hadir. Besok tanggal 24 ada seminar atau webinar yang dilaksanakan oleh Bapeten terkait dengan kegiatan peresmian Indonesian DRL. Dan besok seminarnya akan bisa dilakukan dengan cara webinar atau Zoom meeting. Akan tetapi sore hari ini saya tadi berusaha untuk mendapatkan link Zoom-nya, ternyata harus mendaftar lebih dahulu. Mungkin bagi rekan-rekan yang ingin ingin mendapatkan informasi, saya sudah mencoba untuk mendaftar, tapi sepertinya linknya juga tidak aktif. Saya sudah tanyakan langsung ke panitia sore hari ini juga. Dan saya coba sebentar. Ya, oke. Nanti saya akan share di kolom chat alamat untuk pendaftarannya. Dan kebetulan workshop serta seminar Sri Intan yang dilaksanakan oleh Bapeten pada tanggal 24 Mei 2021 dan peresmiannya pada tanggal 25 Mei 2021 hari berikutnya. Ini salah satu dari anggota atau pengurus pusat PARI menjadi salah satu pembicara. Jadi ada dari radiologis, ada dari fisika medis, dan ada dari radiografer. Tentunya ini materinya tentunya sangat menarik. Jadi silahkan nanti saya akan coba bagikan. Nah, ini sudah saya dapatkan langsung dari panitia. Saya langsung chat ke everyone saja ya, Mas Pli.
Ya, siap.
Ya, sudah saya set s.id workshop Sri Intan. Ya, silahkan bisa melakukan pendaftaran jika teman-teman berminat dengan kegiatan yang akan dilaksanakan oleh Bapeten terkait dengan si Intan dan terkait dengan peresmian Indonesian DRL. Dan sebagai kata pengantar sekaligus penutup dari saya ingin menyampaikan kepada rekan-rekan semuanya bahwasanya kegiatan sore hari ini tadi disampaikan akan mendapatkan sertifikat bagi rekan-rekan yang teregistrasi, mengikuti secara penuh, mengikuti pretest, mengisi absensi, dan mengikuti post-test. Sertifikat ini nanti juga akan dapat diakui untuk SKP-nya dengan melakukan pengajuan. Jadi nggak bisa otomatis ya. Dan mudah-mudahan kedepannya yang di serial ke-6 yang dilaksanakan oleh Vietnam pada tanggal 26 Juni 2021 depan, kita akan coba merelay dengan cara yang benar, cara yang lebih smooth, juga sekaligus sertifikat sudah ber-SKP. Mudah-mudahan ini salah satu upaya dari pengurus untuk memberikan fasilitas yang terbaik buat teman-teman semuanya. Sekali lagi terima kasih kepada segenap panitia, Bli Putu, Mas Gatot, Mbak Putu Irma, Mas Sapi, Mas Ervan, Mbak Zahda Rina, dan rekan-rekan semuanya yang hadir, yang sampai hari ini bertahan 179 orang, alhamdulillah. 179 orang mampu bertahan sampai selesai. Terima kasih. Mudah-mudahan upaya ini bisa memberikan manfaat yang sebesar-besarnya bagi rekan-rekan semuanya dan bisa juga menjadikan salah satu upaya meningkatkan kompetensi kita dan upaya kita mendunia. Radiografer Indonesia bersama sejahtera mendunia. Terima kasih. Dengan ini langsung tutup, Bli.
Ya, silakan Mas Hidayat langsung ditutup. Nanti setelah ditutup acara bebas, kita akan foto-foto.
Ya, sampai situ ya. Dengan mengucap Alhamdulillah, segala puji syukur kehadirat Allah Subhanahu wa Ta'ala, dengan resmi pertemuan webinar CPD Asia kelima. Dengan ini kami tutup. Terima kasih. Billahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Saya kembalikan ke Mbak Irma.
Terima kasih.
Silakan.
Baik, demikian tadi penutupan dari Sekum PP Pari kita, Mas Hidayat Agus Sabarudin. Terima kasih, Mas Hidayat. Dari MC, Mbak Irma, ada yang ingin disampaikan lagi? Silakan, Mbak Irma. Mungkin ada informasi yang lain? Silakan.
Tidak ada informasi tambahan, Bli.
Tidak ada informasi
Sepertinya
tambahan.
cukup ya, Bli ya. Oh ya, mohon Bapak Ibu diingatkan kembali untuk mengisi polling kehadiran dan post-test ya, Bli ya. Dan post-test ya sebagai syarat untuk mendapatkan sertifikat.
Ya, itu post-testnya memang dipilihin pertanyaan yang paling sulit sedunia.
Ternyata
ya,
beda.
Sekarang kita foto bersama. Ada 7 page, ada 173 yang masih bertahan. Tadi sempat menyentuh angka 190 dari 503 pendaftar. Kemudian kita press nama-nama yang double kita hilangkan sehingga kita kirim ke 455 peserta melalui email. Jadi mungkin ada beberapa email yang tidak cocok penulisannya sehingga bounce atau dibalikkan lagi ke sender. Begitu informasi yang dapat saya berikan. Baik, sekarang saya akan ambil gambarnya. Bapak Ibu silakan menghidupkan kamera dan melihat ke arah monitor atau kamera laptop atau HP 1, 2, 3. Itu yang pertama. Baik. Kemudian saya cepat saja, saya menggunakan tools, bisa auto save, 1, 2, 3. Amar, biasa saja wajahnya Mar dari Kalimantan Selatan. Ya, yang keempat, 1, 2, 3. Yang kelima, 1, 2, 3. Yang keenam, 1, 2, 3. Yang ketujuh, 1, 2, 3. Yang terakhir. Ya. Terima kasih Bapak Ibu, rekan-rekan seluruhnya. Semoga acara sore hari ini dapat bermanfaat bagi Bapak Ibu sekalian. Dan
amin.
Mas Gatot, mohon dapat mengirimkan suara. Mas Gatot, mungkin ada yang ingin disampaikan. Mas Gatot Santosa.
Terima kasih sahabat radiografer Desa Indonesia. Selamat berakhir pekan.
Nice. Thank you, Mr. Gatot. You are great. Nice. Thank you. And Irma, we'll see you again, maybe in June 26 or 27 as schedule shown, given.
Ya, mungkin dengan MC yang lainnya, Beli ya.
Why? You good?
Mas Haryadi mungkin ya, untuk bulan depan ya, Pak.
Mr. Haryadi from Jogja. Oh, Mr. Ervan from Kalimantan Selatan, south of Borneo. Oh, Mbak Jahda, yang besok ulang tahun. Selamat ulang tahun Mbak Jahda besok 24 Mei. Selamat. Nggak boleh ya? Nggak boleh ngucapin ulang tahun sebelumnya ya? Oke, Komali. Besok kita rayakan. Baik, besok kita adakan Zoom meeting untuk merayakan ulang tahun Mbak Jahda. Ini adiknya Mbak Jahda, Mar, bener ya kakak besok ulang tahun ya?
Ya.
Acaranya apa, Mar?
Nggak boleh pakai acara.
Oh, nggak boleh pakai acara, baik Pak. Baik,
protokol kesehatan.
Nice, Amar. Ya.
Terima kasih Bapak Ibu. Izin live ya.
Terima kasih.
Terima kasih Bapak Ibu. Mohon maaf apabila ada kekurangan dari MC dan dari acara hari ini. Terima kasih atas kehadirannya. Terima kasih atas waktunya. Terima kasih semuanya.
Nggak ada yang kurang itu laptop saya tadi.
Kelihatan tuh,
mantap beli.
Beli kelihatan tuh tangannya tuh.
Ya, tadi sempat kepantul dia, memang ya laptopnya demikian. Nah, nanti kita setting lagi bagaimana relay yang benar seperti yang disampaikan oleh
Haryadi samaan ya sama kita ya.
Iya, lebih tua itu.
Ini kamera itu.
Semuanya ya, Mas Pak Batin ya.
Ya ini baik, terima kasih Pak Haryadi. Ini sharing yang tadi. Mohon maaf Aren Batin. Pretest ada 245 yang sudah mengisi. Kemudian post-testnya baru saya share. Post-testnya 132 ya. Tidak perlu sempurna, tidak perlu nilai 10 Pak Haryadi, yang penting menjawab saja. Ya, ini banyak yang salah juga. Skornya mestinya 110 tapi ya sebenarnya sulit ya. Tapi ini ada atas nama siapa ini dapat 70 nih, luar biasa ini.
80 tuh.
Arif Apriliano, nice.
Ada 80
ada
lagi beli.
Zan ini alamat emailnya saya bacakan ya. Zanyen Evi itu 80. Ini cum laude sepertinya ini. Memang pertanyaannya USG nggak ngerti. Ya, nanti kita bikin workshop USG yang banyak Pak Haryadi. Baik, soalnya susah-susah ya. Ya, maaf Mar, jangan marah-marah Mar, sabar. Itu semua soal dari kakak Jahda loh, bukan dari saya. Baik, waktu lagi 5 menit, silakan bagi yang ingin mengirimkan pesan-pesan, salam-salam, silakan, selamat bertugas, selamat bekerja. Bagi rekan-rekan ini ada atas nama Mas Fajar Eri ini pakai asmat ini, pakai coverall. Ya, semoga sehat selalu, Mas. Kemudian ini Putu Juli Artana, dia yang protes tadi, rambutnya panjang, kamu kayaknya punya ini deh, mempersiapkan kelahiran buah hati. Kalau di Bali itu kalau rambut panjang itu sudah menyiapkan kelahiran buah hatinya. Begitu. Baik, selamat sore semuanya. Siapa lagi ini? Mbak Jahda, kirim suara Mbak Jahda. Masa adiknya aja yang ribut ini, nggak ada suaranya kakaknya nih. Mas Ervan, terima kasih banyak. Pigeonhole-nya satu pertanyaan aja ya. Saya tadi lihat kok nggak ada yang nanya ini apa fokus sama materinya sehingga tidak ada yang ingin bertanya gitu. Tapi apapun tadi pertanyaan kita sudah posting. Apakah Monte Carlo saja? Ya menurut mereka sih Monte Carlo yang terbaik gitu ya tadi yang kami dengar gitu. Oke, sampai jumpa lagi di kesempatan lainnya. Terima kasih atas waktunya, kebersamaan hingga sore hari ini. Kami masih menantikan suara dari Mbak Jahda. Terus tadi siang juga kami sempat video call bersama ya, bersama dengan Mbak Nuning juga untuk mengetahui keadaan beliau. Dan Mbak Nuning merespon video call kita, keadaan beliau baik. Tadi per video call tadi kita bersama-sama. Dan kita doakan semoga Mbak Nuning, tim kami di HSIT segera sembuh, diberi kesehatan, dan kembali bugar hingga bisa bersama-sama kita lagi di acara yang lainnya. Baik. Amin, Pak Haryadi. Terima kasih Pak Haryadi. Mohon bimbingan selalu. Diinget-ingetin. Terima kasih loh tadi loh. Oh iya, kelihatan baju saya aja semua kelihatan jadinya. But it's okay. Mbak Jahda kirim suara. Aduh, dari tadi ditunggu suaranya nih, nggak ada suaranya nih.
Sudah ya, Bli? Saya pamit dulu, Bli.
Terima kasih Mas Hidayat. Sampai jumpa lagi.
Sampai jumpa lagi.
Ini lagi 2 menit saya stop. Saya langsung akhiri. Dan link untuk post-test, ini baksonya udah nggak sabar deh. Link untuk post-test masih dibuka hingga pukul 22.00 WIB nanti malam. Jadi masih bisa diisi sampai malam hari nanti.
Bakso ngumpet, Bli. Cepetan ngumpet, Bli.
Gimana?
Ada tukang bakso ngumpet.
Iya ya, saya curiga itu tumben-tumben loh. Biasanya ini kompleks nggak ada tukang bakso yang lewat. Tiba-tiba ada tukang bakso.
Kayak bintang Emon kamu.
Iya, agak gemeter nih lutut saya nih tiba-tiba nih.
Bli.
Ya.
Izin, Bli. Salam semuanya.
Bli, minta
Terima
dibantu.
kasih Pak Haryadi.
Untuk Bli, tadi saya share gambarnya Mas Eka atau Pak Eka untuk dioptimalkan. Barangkali
Oh iya, siap.
Ya.
Siap Mas Hidayat.
Ya.
Oke, sampai jumpa lagi Mas Hidayat. Terima kasih. Saya izin.
Masih ada 114 Bli yang masih online itu. Kita sapa
ya, kayak masih ngerjain tesnya.
Mas Kresna Yuda, ada Mas Misbahul, Mas Fajar Eri, Mas Arman, Mas Putu Juli Artana, Mbak Neni Nurleli, Mas Angga, Mbak Anggi, Mas Amar. Wah, Mas Amar kesebut lagi. Betty, Mbak Betty, Mas Ahmad, Alal, Mas Zakaria, Mas Angga sudah, ya Mbak Tri Handayani, Mas Safi'i sudah pakai hazmat overall.
Ya.
Pak Dadang Sitanggang, maaf Pak Dadang. Terima kasih Pak Dadang atas atensi dan perhatiannya. Ya, terima kasih Pak Dadang. Ini memberikan semangat buat kita yang muda ini harusnya nih. Pak Dadang aja masih sampai sore ini masih bisa.
Sore kuat ya.
Iya. Oke. Dan yang lainnya, Pak Dadang, sampaikan salam Pak sama teman-teman yang lain Pak. Silakan Bapak sampaikan salam Pak.
Pak Dadang, sehat selalu. Mantap.
Silakan Pak, mic-nya dibuka saja nggak apa-apa, acara bebas ini.
Ya, bisa.
Salam, sehat selalu.
Pak Dadang di mana Pak? Pak Dadang lagi di mana Bapak?
Di rumah Pak.
Oh, di rumah. Ya. Di Medan Pak?
Baru istirahat.
Oh, gitu. Istirahat sambil mendengarkan materi. Wah, mantap Pak. Masuk semua itu Pak, materi Pak ya?
Kadang Pak.
Ini memang benar-benar belajar sepanjang hayat.
Atensi dan supportnya, ya. Ada Mas Jaka yang selalu Jaka ini. Kalau di Jawa jadi Joko ini sebenarnya ini. Mas Jaka, apa kabar Mas Jaka?
Sehat Pak, sehat.
Alhamdulillah.
Alhamdulillah, sehat Pak Dayat.
Ya, siap Mas Eka. Sedang di mana ini?
Lagi di rumah Pak.
Di rumah. Hari Minggu ya. Terima kasih. Semangat.
Iya, Pak.
Menemani kita.
Siap.
Terima kasih. Sehat selalu, sehat selalu.
Siap Pak.
Ya, buat rekan-rekan yang lain yang ada fotonya tetap saya sapa meskipun di sini ada namanya Mas Bartolomeus, Mbak Nisrina, Mbak Novi, Mas Montana, Mbak Wanda, Mas Arif Cahya, Mbak Retati Bansua, Mbak Heni. Oh, ada Mbak Heni. Mbak Heni masih bisa monitor. Heni Purnawati.
Ya, lagi bersiap lift. Anakku bangun.
Ya, sehat selalu Mbak Eni ya, terima kasih sudah dampingin kami, sudah semua ikutan acara sampai sore ini ya. Mbak Alfiati, Mas Abdurrahman, Mbak Nur Hidayanti, Mbak Devi Meiza, Mbak Atika, Mas Atika ya, Pak Purwantono, munculkan Pak gambarnya Pak. Wah, ini diam-diam ada Pak Mas Pur nih. Pak Pur. Ya, Mas Aji Prastowo, Mas Agus Salim, Mbak Asri Sugiyarti, Mbak Arieva, dan yang lainnya. Terima kasih. Mudah-mudahan kita semua diberikan kesehatan, keselamatan selalu, ya. Tetap jaga kesehatan, tetap jaga diri dengan protokol kesehatan, jangan sampai sakit, ya, apapun itu. Mudah-mudahan, ya.
Yang ada hanya di dalam Tuhan apa?
Yuda, sini kau Yuda.
Abdurrahman, dari mana ini Mas Abdurrahman? Langsung hilang. Ya, Mas Agus Winarko, Mbak Baik Nova, Adita Victoria Putri, Susilo Kurniawan ya, Maya Purnama, Evaliana, Khairul Tunisa, Stanislaus Yu, Lia Sheran, ada Mbak Rosi, ada Priska Ramadhani.
Halo.
Ya, Mas Abdurrahman Siddiq. Apa kabar, Mas?
Saya ini ada yang nanya, pengajuan sertifikatnya kemana ya? Saya Mas ya? Sekretariat PP Pari ya? Yang pengajuan sertifikat untuk sebagai SKP itu, Mas.
Oke,
ini ada yang nanya.
Nanti kita coba sebelum kita share sertifikatnya, apakah mungkin kalau misalnya kita coba diskusikan dengan tim,
gimana Pak?
Ya, kita diskusikan dengan tim verifikator sertifikat SKP Pari, apakah bisa langsung terbit, jadi nanti langsung masuk siap Pari, terbit, sudah ber-SKP, ya, mudah-mudahan nanti coba kita diskusikan kembali. Ya.
Oke, terima kasih.
Tapi ini nanti coba kalaupun ada pengajuan, nanti kita coba juga ada prosedur yang kita lampirkan untuk pengajuannya seperti apa. Ya, terima kasih, Li.
Baik, terima kasih Mas Hidayat.
Ya, oke. Pamit saya.
Sama-sama. Ya, saya juga pamit. Terima kasih Mas Hidayat.
Juga istirahat nih. Ya, terima kasih. Sampai ketemu lagi. Assalamualaikum warahmatullahi wabarakatuh.
Sampai jumpa.
Semuanya. Salam. Ya.
Ya, saya end meeting ya Mas ya.
Ya.
Mari.